So you want to? There we go. Good morning, everyone. Thank you for being here. This is quite the turnout. Yale New Haven Health Services Corporation and Prospect CT Inc., the applicants in this matter, seek a certificate of need for the transfer of a healthcare facility pursuant to Connecticut General Statutes, section 19A-638A-2. Specifically, they seek to transfer Prospect's Connecticut-based hospital systems, that is Manchester Memorial Hospital, Rockville General Hospital, and Waterbury Hospital, their imaging equipment, and certain equity interests in certain joint ventures, all to Yale. There is a separate certificate of need application for the transfer of Prospect's Medical Foundation to Yale's Medical Foundation, which, although related, is not the subject of today's hearing. Today is April 26, 2023. My name is Daniel Chuka. Dr. Deidre Gifford, the Executive Director of the Office of Health Strategy, designated me to serve as the hearing officer for this matter, to rule on all motions and to recommend findings of fact and conclusions of law upon completion of the hearing. This is a hybrid hearing. This is the first in-person hearing that OHS has done in quite some time, since before COVID. So it's been over 3 years at this point. By hybrid, I mean it is being held both in person and electronically via Zoom. Public Act number 21-2, as amended by Public Act 22-3, authorizes an agency to hold a public hearing by means of electronic equipment. In accordance with this legislation, any person who participates orally in an electronic meeting shall make a good faith effort to state his or her name and title at the outset of each occasion that such person participates orally during an uninterrupted dialogue or series of questions and answers. For anyone attending remotely, unless you are actively participating in the hearing, either as one of the applicant's witnesses or as a member of the public providing comment at the designated time, I ask that you mute your device and silence any additional devices that are around you. I will get more into this later on, but public comment for right now is scheduled to begin at 3 o'clock. That assumes that we get through all of the technical portion by then. If we don't get through the technical portion by then, I may sort of push that back, but I do understand that we have some elected and appointed officials who do want to make some comments, so I'll take them, at around 3 o'clock. And if there are any other physicians or executives for either of the hospital systems who are tight on time, we can take them at the same time. This public hearing is held pursuant to Connecticut General Statutes, section 19A-639A, sub F, sub 1. As such, this matter constitutes a contested case under the Uniform Administrative Procedure Act, and it will be conducted in accordance therewith. I do have some Office of Health Strategy staff here with me to assist in gathering facts related to the application, and they will be asking the applicant's witnesses questions. I will also be asking questions. At this time, I'm going to ask that each of the staff persons assisting me identify themselves with their names, spelling of their last name, and OHS title. I think all of our names are on placards, but if we can start with you, Roy.
Sure. Good morning. My name is Ronan Wong. I go by Roy, and I'm an associate research analyst with the Office of Health Strategy.
Thank you.
Morning, my name is Bolana Kashti, and I'm an associate healthcare analyst.
Hi, my name is Stephen Lazarus, Lazarus, and I'm the Certificate of Need Program Supervisor.
Thank you. Up until yesterday afternoon, we had expected to have another staff member with us as well, but he can't be present today unexpectedly. We're going to do our best to sort of fill in the blanks and address any issues that present as they arise. I don't think we'll present any issues, but I just wanted to bring that up in the event there are any hiccups. Also present in the other room are Betty Ventus and I believe Leslie Greer as well, who are also OHS staff members, and they're going to assist with gathering names for public comment, both virtually and in person. The certificate of need process is a regulatory process, and as such, the highest level of respect will be accorded to the applicants, members of the public, and our staff. Our priority is the integrity and transparency of this process. Accordingly, decorum must be made by all present during these proceedings. This hearing is being transcribed and recorded, and the video will also be made available on the OHS website and its YouTube account. All documents related to this hearing that have been or will be submitted to OHS are available through our certificate of need portal, which is accessible on the OHS CON webpage. In making my decision, I will consider and make written findings in accordance with section 19A-639 of the general statutes. And lastly, for anyone attending remotely, as Zoom hopefully notified you in the course of entering this hearing, I do want to point out that by appearing on camera in this virtual hearing, you are consenting to being filmed. If you wish to revoke your consent, please do so at this time, either by exiting the Zoom meeting or by exiting this hearing room. As you can see, the camera over there is picking up pretty much everybody in this room. So let's see. Now onto the substance. I'm going to start by going over the exhibits and items of which I am taking administrative notice. And then I will ask if there are any objections. The CON portal contains the pre-hearing table of record in this case. At the time of its filing this past Thursday, exhibits were identified in the table from A to R. On Monday of this week, I issued and had uploaded to the record a notice regarding parking and in-person access. I'm going to identify that right now as Exhibit S. That's S as in Sam. I also note that the applicants uploaded some additional support letters yesterday. That will be Exhibit T. And although the agenda was posted to the OHS hearings and meetings webpage and the Secretary of State site this past Friday, it was not uploaded to the CON portal until last night. So that'll be Exhibit U. We also think that covers it. So Steve, Roy, do we have any other exhibits that we need to enter for the agency at this time?
I don't believe so.
I see a presentation and a attendee list that were uploaded on the 26th.
Okay. And those are two separate filings?
Two separate filings.
Okay. And I believe that references the PowerPoint presentation by Mr. O'Connor, is that correct?
That's correct.
And what was the other one?
It's a prospect Yale New Haven attendee list.
Okay.
It was the one that was sent. We referenced earlier.
Okay.
Yeah.
So the attendee list will be B, and then the PowerPoint presentation W. Sorry, I had to go through the alphabet. Right? You guys are asking a lot of me. The applicant is hereby noticed that I am taking administrative notice of the following documents. The statewide healthcare facilities and services plan and its supplements, the facilities and services inventory, the OHS acute care hospital discharge database, all payer claims database claims data, and the hospital reporting system, that's the HRS financial and utilization data. There are also some dockets that I'm going to be taking specific administrative notice of at this time. One is docket 20-32405. That's docket for the application filed by Prospect DCHN, Prospect Manchester Hospital, and Prospect Rockville Hospital, related to the consolidation of hospital licenses. I'm also taking administrative notice of 18-32270. That's Yale's acquisition of Milford Hospital by Bridgeport Hospital. 15-32016-486. That's the docket pursuant to which Prospect acquired ownership of the three hospitals at issue in this docket. Docket 12-31768, which is Yale's acquisition of Lawrence Memorial Hospital. And then the final two, I couldn't find docket numbers for yesterday. One is Yale's acquisition of Greenwich Hospital from 1998 and Yale's acquisition of Bridgeport Hospital from 1996. I'm not expecting to have to rely on any of those for any specific purpose, but I did want to mention that since those do to some extent relate to today's proceeding, I may be referring to those at some point.
Carry on, Mr. Chico, we don't have an objection to noticing those prior transactions. In fact, we were going to request it, but our numbering is slightly different on the numbers for the CONs.
Okay.
And I don't know if you mentioned St. Rachel's, the acquisition of St. Rachel's, we'd like to add that as well.
I did not.
We're happy to check at the break and go over the numbers and make sure we have the correct numbers referenced.
That would be great. Thank you.
And I guess we have no objection to noticing the consolidation proceeding and the events that occurred. We would object to the extent that there's a proposed decision that's not final, to the extent that that is not, final decision at this point.
Understood. So that I'm clear going forward, I know that there are two attorneys here, so if you're objecting on behalf of Yale. Should I also impart that objection on Ms. Volpe, or should I just assume?
Yeah, that's fine.
Okay.
Kim's gonna speak on the applicant's behalf today.
Okay, thank you very much.
I'll speak when spoken to.
Okay.
That's me to vote for me.
Thank you for clarifying that. So counsel for the applicant, Yale New Haven Health Services Corporation, can you please identify yourself for the record?
My name is Kim Reinhardt. The last name is spelled Reinehart, from the law firm of Wigan and Dana. And I'm representing Yale Health System. I know that there was a request to identify abbreviations that are likely to be used. And so for the benefit of these folks not having to do that, you may hear Yale Human Health Services referred to as YNHHS, or sometimes by folks that work there as the system. I think there's also references going to be made to ECHN, which is, the health system that operates Rockville and Manchester. So that hopefully will be clear on the record. And I just wanted to take a moment to thank the hearing officer Chica as well as OHS staff for having us today. And especially for taking on the challenge of doing a hybrid hearing, allowing for both in-person presence and the maximum amount of public engagement. We think this is a really important project, and we really appreciate the opportunity to have as much public, input as possible in the process. Shall I go ahead and turn it over to Chris, or do you have other procedural matters?
I hadn't see. So subject to your one objection, I hadn't entered any of the exhibits as full exhibits, so I am going to enter those right now as full exhibits. There are a few other things I did want to try to get through before we moved on to that. So there was an agenda that was uploaded. So we're going to proceed to the greatest extent possible in the order in which it's listed in the agenda. I would like to advise the applicants and the witnesses that we may ask questions related to your application that you feel you have already addressed. We will do this for the purpose of ensuring that the public has knowledge about your proposal and for the purpose of clarification. I also want to reassure you that we have reviewed your application, completeness, responses, and pre-file testimony, and I will do so many, many times before issuing a decision. As this hearing is being held in hybrid fashion, again, we ask that all participants attending via Zoom, to the extent possible, enable the use of video cameras when testifying or commenting remotely. And I also wanted to mention that since it's partially remote, when we go on breaks, anybody who's attending should mute their devices, turn the camera on, that sort of thing. Because in the event it continues to record, anything you say or do will remain on camera. Same thing goes for the people in this room. Keep in mind that the video recording may continue. And even if it doesn't, you will still be viewable to everybody attending by the Zoom. So as I mentioned earlier, public comment during this hearing will likely go in the order established by OHS during the registration process. However, I may allow public officials to testify out of order. I or OHS staff will call each individual by name when it is his or her turn to speak. Registration for public comment has already begun and is scheduled to start at 3 p.m. If the technical portion of the hearing has not been completed by 3 p.m., public comment may be postponed. And the applicant's witnesses must be available after public comment, as OHS may have additional follow-up questions based on any of the public comment. So are there any other housekeeping matters, Attorney Reinhardt, that you wanted to address at this time?
I think this is clear, but the public officials that we've already let you know about are already considered to be registered, correct? They don't have to do anything separate.
Yep,
Thank you.
we've taken notice of those and their names have been added to the list. So with that, we're going to move on to the technical portion. Is there an opening statement, Attorney Reinhardt or Attorney Volpe, that you wanted to make at this time?
I would just say during our certificate, we put together a large number of materials, and we believe those materials combined with pre-filed testimony, clearly show that the statutory factors are met. As I mentioned, so this is a very important transaction, and we're obviously here and waiting to answer any questions that you and the staff have. I know before we turn it over to Chris, we do need to get everyone sworn in. So thank you very much.
So that's the next step. If you can identify all the individuals by name and title who are planning to provide any remarks today, that would be great. And then I will swear them all in at the same time.
And in terms of remarks, do you want only the list of people who will be making affirmative remarks, or also those that you anticipate may need to be available for answering questions?
Let's just do them all at once. That way you don't have to swear people in individually.
That's perfect. It maybe just makes sense then to go along the table starting at the end and let each person introduce themselves and also prove back so they can provide their titles as well.
Okay, perfect.
Great. Mark Crockett, Prospect Medical Holdings, Senior Vice President.
Deborah Weymouth, President and CEO of Eastern Connecticut Health Network.
Justin Lundby, President, CEO of Waterbury Health.
Michelle Volpe, counsel for Manchester Memorial, Rock Hill Hospital, Waterbury Hospital, and Prospect CT is the parent of those 3 hospitals, and their CON council.
Hi, Tom Balsazar, I'm the Chief Local Officer for Yale Haven Health.
Good morning, Chris O'Connor. I'm the Chief Executive Officer for Yale New Haven Health.
Kim Reinhardt, counsel for Yale Health.
Good morning, Bill Azeltine, Executive Vice President, Yale New Haven Health, Chief Legal and Administrative Officer.
Good morning, Ann Diamond, President, Bridgeport Hospital.
Good morning, Gail Kosla, Chief Financial Officer of Yale Haven Health. Lisa Stump, Chief Information Officer for Yale New Haven Health and Yale Next. Melissa Turner, Chief Human Resource Officer at Yale New Haven Health.
Okay. So I'm going to ask anybody who, well, other than the attorneys, anybody who just introduced themselves to raise their right hand at this time. Do you solemnly swear or solemnly and sincerely affirm, as the case may be, that the evidence you shall give or have already given in this case shall be the truth, the whole truth, and nothing but the truth, so help you God, or upon penalty of perjury?
I do.
Thank you. So when giving your testimony, make sure that you state your full name and adopt any written testimony you may have submitted on the record prior to testifying today. And with that, the applicants can now proceed with their testimony. And Attorney Reinhardt, you can start whenever you're ready.
Yes, Chris O'Connor is going to be leading up for the Yale Health, and he has a PowerPoint which hopefully is going to be displayed for everyone.
Flawlessly. Good morning, and like Kim, I want to express my gratitude to all of you, and particularly hearing officer for your oversight of this important day today. My name is Chris O'Connor. As I mentioned, I'm the Chief Executive Officer of Yale New Haven Health. I've been a part of the Yale New Haven Health System for over a decade, and I entered through the acquisition of the Hospital of St. Raphael, where I was the Chief Executive Officer at that time. Through that acquisition, I saw firsthand how transformative it can be when a community hospital is acquired by an academic health system like Yale New Haven Health. St. Raphael's has been completely revitalized as a result. I am excited here today to talk about our proposal to acquire Prospect, Connecticut hospitals. It is a momentous challenge given the current financial environment for hospitals, but also a momentous opportunity. An opportunity to bring these hospitals back under local leadership and ownership so that resources are invested back into the community to convert the hospitals back to not-for-profit status, putting patients first, and to bring Yale New Haven's unique world-class signature of care to Waterbury and the ECHN regions. Next slide. I said flawlessly too words. Take on this challenge not because it's easy, but because it's consistent with our mission, vision, and values. We are focused on people, not profits. Our goal is to enhance the lives of people we are serving by providing access to high-value, patient-centered care. And we believe we can bring a substantial value to the Waterbury and ECHN communities. By way of overview, this proposal focuses on Yale New Haven Health's acquisition of Waterbury Hospital and the ECHN hospitals, Rockville and Manchester. And if this proposal is approved, we plan to operate Waterbury Hospital as a standalone licensed hospital and Rockville and Manchester that are as two campuses under a single licensed hospital. This is because Rockville and Manchester are less than 10 miles apart and have already been operationally integrated. Additionally, both hospitals are currently underutilized, and combining them will allow us to build on the strengths of each campus, as my colleague Tom Balsazak will discuss further in a moment. We've used this approach successfully in prior transactions involving small community hospitals, including the Hospital of St. Raphael, which became the St. Raphael campus of Yale New Haven Hospital, and Milford Hospital, which became part of the Bridgeport Hospital license. This proposal also includes the acquisition of hospitals' imaging equipment. These items are already owned by the hospitals, and they will continue to be owned and used by the hospitals post-transaction, as well as certain joint venture interests that are held by the hospitals or affiliate entities. Additionally, overall, the transaction involves the acquisition of Prospect Medical Foundation by the Yale New Haven Health Medical Foundation Northeast Medical Group. That aspect of the transaction, as you mentioned, is being reviewed under a separate CON. And we will also purchase Prospect's home health business in Connecticut. Prospect made the choice to sell these hospitals, putting out a request for proposal. So this is not a situation of whether the hospitals will be sold, but to whom. Yale New Haven Health is a clear pro-competitive choice to acquire the Prospect hospitals. It is my understanding that aside from Yale New Haven, Prospect received two other proposals to acquire hospitals, and both came from large Connecticut health systems, with existing acute care hospitals in the same geographies. On this map, we've identified the Prospect hospitals in red circles and the existing Yale New Haven hospitals in blue circles. The other symbols reflect other hospitals. As you can see from the map, while there are other hospitals in the proximity to the Prospect hospitals, Yale New Haven Health has no existing acute care hospitals in the Waterbury or ECHN service areas. Thus, Yale New Haven's is the only choice that maintains patient choice, provider diversity in the region. We also believe that as a high quality system with strong ties to our academic subspecialty care, we can bring a more active competition to the region. This proposal will also bring significant benefits to patients. We will bring Yale New Haven's world-class care signature to Waterbury and the ECHN communities. By bringing expert resources from Yale Medicine and the Yale New Haven Health System into the hospitals, we will be able to enable more patients to receive care closer to home, even for more serious conditions. When truly complex conditions emerge, transfer to a higher level of care will be seamless, enhancing the continuity of care. We will also implement EPIC, the gold standard in electronic health records. This will allow patients to have a seamless access to all of their health records in one convenient place. All major benefit for all of them, another major benefit, if I can read, for patients is the implementation of our more generous financial assistance policy. The transaction will also benefit employees. Yale New Haven has agreed to assume all collective bargaining agreements, hire substantially all employees, and provide benefits that are comparable or better to their existing benefits. Over time, we believe that Yale New Haven will be able to attract additional providers and employees to the hospitals. Prospect has actually told us they're already seeing more interest since the announcement of this potential affiliation. We pride ourselves in being an employer of choice, and we've gotten many recognitions for being a great place to work. We also expect the transaction will not increase costs of healthcare services in the state. Medicare and Medicaid rates are set by the government and will continue to be set by the government going forward. We've agreed to assume Prospect's commercial rates subject to payer consent. So there too, we don't expect the transaction to impact costs. And as I noted, for self-pay patients or insured patients with balances, they will have access to Yale New Haven's far more generous financial assistance policy. For example, individuals who make up to 250% of the federal poverty level are eligible for free care under Yale New Haven's policy, while currently patients must make less than 125% of the federal poverty level to receive free care at Manchester or Rockville, and less than 200% of federal poverty level to receive free care at Waterbury. As explained in our application and in my pre-filed testimony, the Prospect hospitals have been facing significant financial headwinds for a number of years. These challenges are rapidly growing more acute. For example, Prospect's draft financial 2022 financials showed an increase in the net loss from fiscal year 21 of a negative 15 million to negative 49.5 million in fiscal year 2022. Thus, there is a clear need to allow these hospitals to be acquired so they can be financially stabilized and revitalized. Ultimately, you should not trust what we say, but what we have done. Our track record speaks for itself. We've successfully integrated multiple community hospitals since 2012. In each instance, they were facing major financial struggles at the time, and each time we managed to increase utilization, expand services, enhance quality of care, achieve forecasted cost savings, invest in facilities to address the community needs, and preserve jobs. I'd like to speak a bit more about the specific experience involving the acquisition of the Hospital of St. Raphael. As I mentioned, that transaction is very personal for me, as I was the CEO of St. Raphael's at the time. My mother also worked at the hospital for a nurse for over 40 years. It was a difficult decision to be acquired, as the hospital had been a proud independent institution for a very long time. And there was a fear that it could lose its character, particularly because it would no longer be independent, but instead would become a campus of the Yale New Haven Hospital. However, I also recognize that the hospital was in a very difficult position, and it was clear that it could not continue to survive and thrive in a changing healthcare environment. The transaction proved to be extremely successful for both St. Raphael and the Yale New Haven Hospital. We were able to maintain many aspects of the distinct character of the hospital, and the acquisition allowed us to invest in the campus and address the pension liabilities. For Yale New Haven Health, the transaction provided a cost-effective solution to address overutilization at the York Street campus. Through the acquisition, almost 3,500 employees were seamlessly integrated with no gaps in pay and benefits. And over time, significant investments have been made in the St. Raphael campus, including the most recently development of a neuroscience tower. While we're dealing with a much more difficult time financially for hospitals, I believe we have similar opportunities to revitalize the Prospect hospitals. We're committed to not only maintaining Prospect's current community engagement programs, but to growing them. Yale New Haven has consistently been recognized for its community benefits contributions. The Office of Healthcare Strategy most recent community benefit report found that Yale New Haven provided more community benefit than its peers, regardless of what the weighting factors were used. Moreover, bringing these hospitals back to under local ownership will ensure that resources are back invested into Connecticut. Reversion of not-for-profit status will also ensure that the focus is where it should be, on patients, not profits. As I've said, this transaction, this is a readable chart, offers the opportunity to financially stabilize the Prospect hospitals, but it won't be easy. This is a very difficult time for all of Connecticut hospitals in the wake of COVID-19 pandemic, and Yale New Haven Health is dealing with its own challenges. This slide is our revised worksheet A. And as you can see, certainly not by reading the PowerPoint, we are beginning from a very difficult starting point with significant losses as a system in fiscal year 2022. Adding the Prospect hospitals will bring incremental losses for the next several years. Ultimately, we believe we have the ability to achieve a positive total margin for the system overall by fiscal year 2024 and a positive operating margin by 2025. However, this model assumes that we can meet our own deficit mitigation targets and have the flexibility to operate the Prospect hospitals in an effective manner. It also assumes reasonable market returns over the next several years. Thus, there are real risks. This is an undoubtedly enormous undertaking. But as John F. Kennedy once said, we choose to take on these challenges, not because they are easy, but because they are hard. Because that goal will serve to organize and measure the best of our energies and skills. Because that challenge is one that we are willing to accept. One that we are not willing to postpone. I strongly urge you to move rapidly to improve the application without conditions so that Yale New Haven can get to work revitalizing these hospitals and serving the surrounding communities. Let me turn it to Dr. Balsazar.
Thank you, Chris. Good morning, everyone. Thank you for the opportunity to provide this testimony. My name is Tom Balsazak, and I would like to adopt my pre-filed testimony. I'm the Chief Clinical Officer of Yale New Haven Health System, and in that role, I will oversee the clinical integration of the Prospect hospitals as well as the clinical planning for each campus. I bring to this table and to this testimony more than 30 years experience of working at Yale New Haven Hospital and Yale New Haven Health. I first came there as a medical resident trainee, then as a student and graduate of the School of Public Health at Yale, then as a junior faculty member. And for 17 years, I was a community practitioner in primary care. I was an internist primary care physician in Branford, Connecticut. Chris mentioned to you that more than 10 years ago, we acquired and integrated the Hospital of St. Raphael's into the Yale New Haven Health System, specifically as a campus of Yale New Haven Hospital. At that time, I was the Chief Quality Officer for Yale New Haven Hospital and the Associate Chief Medical Officer, and experienced firsthand much of what Chris just described. Based on that experience and the subsequent experiences of acquiring and integrating Milford campus of Bridgeport Hospital into the Yale New Haven Health System and the Lawrence Memorial Health System, meaning Lawrence Memorial Hospital and Westerly Hospital, I believe there are enormous benefits of bringing community hospitals into the Yale New Haven Health System because of our foundational academic medical center. New Haven, with its 1,500 bed academic medical center, is a world-class facility that provides exquisite care with the Yale School of Medicine faculty to thousands of patients across multiple states every day. The concept of an academic medical center founding an academically based health system is relatively new. And the concept is that we can bring the right care to the patients in their home institutions where possible, and we can expand those services. And we've proven that at each one of our previous acquisitions. There are many ways that we can demonstrate how that's done. And I'm going to go through a couple of them. One is through, as Chris mentioned, EPIC, which is our electronic medical record. Back in the year 2000, when To Err Is Human, the seminal Institute of Medicine publication, was published about safety in American hospitals, one of the main things they pointed to improve quality of care was the institution of what was called then CPOE, or computerized physician order entry. That was really the first step in the integrated electronic medical record, and it was really a very small step. We have taken that far beyond computerized physician order entry, and we now have a single instance of EPIC, which is extremely important across all of the places where Yale New Haven Health operates. This is in contrast to the prospect hospitals that have different instances of different electronic medical records at their different locations. What functionally does that mean? Well, it seems bizarre that in this day and age that electronic medical records do not communicate with one another, but unfortunately that's the situation that we are in, except when you have a single instance of that electronic medical record. With that single instance of EPIC, we are able to show that care is much more efficient. We can drive consistency of care, something we call care signature, and we can demonstrate efficiency and care enhancements. It makes transfer from outlying facilities or outlying physician offices seamless. It ensures that their care is both efficient and effective. So the combination of that electronic medical record, which is really an avenue to stitch together high quality care across the different domains of care and across different providers, is really emblematic of one of the things that we can do to provide. When we acquired Lawrence Memorial, for example, we both were able to populate their medical staff with specialists from Yale School of Medicine and bring the technologies like EPIC to bear at Lawrence Memorial. And what we were able to do at Lawrence Memorial was we were allow them to retain a much greater percentage of patients at that hospital than had previously been retained. This is an example of what Chris was talking about, how our goal is to deliver right care in the right place. There are still some instances, for example, Lawrence Memorial does not provide cardiac surgery, does not provide transplant surgery. So those patients naturally would be transferred to the academic medical center. It's both ineffective, unsafe, and inefficient to reproduce all kinds of care at every institution. But there are certain circumstances where you can provide very safe, high quality tertiary care in a community setting. That's our goal. And that's what we've been shown to do at the previous, acquisitions. There are numerous publications showing that care at academic medical centers is both more efficient in the long run and certainly more effective with better outcomes in terms of quality outcomes in terms of things like mortality. And we believe that we've demonstrated that. And in fact, we've published that a number of times in certain circumstances within our health system. One of the most recent examples of the strength of the Yale New Haven health system, the strength of the School of Faculty integrated across our health system with backbones such as a common medical record, EPIC, a common pharmacy standard, et cetera, is our EPIC pandemic. You may have seen that in the national press, Yale New Haven Hospital has been lauded as one of the institutions in the United States with the lowest mortality throughout the COVID pandemic for the treatment of COVID patients. And our own internal data, which is soon to be published, demonstrates that there's not a statistically significant difference between the mortality of the patients cared at Yale New Haven and our affiliate hospitals that are part of the health system. That means that if you're in the community hospital in Westerly, New London, Bridgeport, or Greenwich, and you sought care at that institution with COVID, and you stayed in that institution for the treatment of COVID, you experience the same high quality care and the same good outcomes as if you were in the academic flagship. For us, that's success. Our goal is not to bring every patient to New Haven. In fact, we cannot. New Haven runs at a 95% current occupancy. Our goal is to keep patients where possible in the communities where they are cared. The way we did this was to use our EPIC medical record backbone, source the ever-evolving clinical pathways from our Yale School of Medicine and other experts, and we reiterated that clinical care pathway for the treatment of COVID patients more than 200 times since March of 2020, because the knowledge has continued to evolve in how to care for COVID patients. You may remember if we were sitting in this room 3 years ago, no one would have understood how to care for COVID. Today, we know how to do that. In large part, the way we've been able to learn how to care for COVID patients as an evolving disease has been driven by the researchers in the Yale School of Medicine, and we immediately transmit that knowledge into our care pathways, which then every clinician across our health system can immediately follow that same day. That's really unique, and we believe that that is a real evidence, an empiric demonstration of the value of an academic medical center. That's the kind of care we want to bring to Manchester, Rockville, and Waterbury Hospital. So how have we gone about the clinical planning? I can't say that our clinical planning has been complete. There are issues with antitrust and other that have prevented us from getting our hands on certain documents, contracts and such that allow us to do a complete comprehensive study of each hospital to identify each of its strengths, weaknesses, gaps, community needs, et cetera. We would like to do that immediately upon completion of the transaction. And we believe we can do that within 6 months and really hit the ground running. The good news is that the quality of care and the services are generally strong across both ECHN and Waterbury Hospital. Let me address the two of them. At Waterbury Hospital, our initial focus is really going to be around stabilizing the systems of care. The transition, as we've experienced at both L&M, Milford, and with the St. Raphael's transaction, is there's a real concern around the transition between one entity to another, and making sure that high quality care and continuity is established during the time of that transaction. We have experience in doing that. We can do it, and we've been demonstrated that patient care will continue seamlessly, that we were able to pay our bills, we were able to keep our staff paid, and that we were able to create a smooth transition from a one ownership entity to another. We would then begin strengthening the services. We think there's initial opportunity to strengthen already strong offerings in oncology, heart and vascular disease, and maternal fetal medicine. Same with Manchester and Rockville. Manchester and Rockville, as well as Waterbury Hospital, the ECHN and Waterbury Hospital are interesting institutions as we've looked at them. They both serve about the same size population. They have roughly the same number of beds. They both have about a little more than 1,000 deliveries. They're quite similar in many ways, even though Manchester and Rockville are two institutions. Chris mentioned that our intent would be to bring Rockville and Manchester and operate them under a single license. We believe that that is the best way to provide high quality and safe care. Now, we have a number of experiences where we've done similar things. We have a freestanding emergency department in Guilford, which is open 24 hours a day, 7 days a week. We see surgical cases there that are transferred from Guilford to New Haven or New London. We see heart attacks there. We see all manner of emergency care at our Guilford freestanding emergency department. That Guilford freestanding emergency department is 12 miles from New Haven. We have an outstanding safety record and a high quality record for getting those patients safe, high quality care as they're transferred from that ED to New Haven for their care. Our intent would be to continue to operate the emergency department in Rockville, augment it and add outpatient services and study what we would like to do there on the inpatient side. But we would like to operate the two as a single institution. Same is to be said, I think, and Ann Diamond is going to talk about our experience with Milford and Bridgeport that we operate under a single license. When we acquired Milford, and Ann will go into this detail, its inpatient census was lagging. Their quality of care was in question. We were able to stabilize that. And today, as Ann will tell you, Milford is very busy with high quality care, overseen and integrated completely with Bridgeport Hospital, which is almost exactly 9 miles away, as are Manchester and Rockville. Well, both hospitals, as you can see from the data, are underutilized currently as compared to their number of staff beds or operating beds as compared to the number of licensed beds. And we believe, like we've demonstrated in Lawrence Memorial, Westerly, and in Milford, that we have an opportunity to increase that census as we bring high quality programs to those and staffing into those markets. We believe that there are lots of patients leaving those geographies, driving past those institutions, going to other institutions that would be better served by being cared for closer to home. I'm mentioning Rockville. Rockville currently right now has an inpatient census, I believe, of 3 patients on average, 3 med-surg patients on average per day. And they operate their inpatient surgical cases about a half day per week. This is unsustainable and unsafe. Low volumes have been repeatedly shown to be associated with poor clinical outcomes in virtually every clinical setting that they've ever been studied. Not seeing enough patients to maintain or hone your skills, whether you're a physician, a respiratory therapist, nurse, surgical tech, and anesthesiologist, just is not sustainable. But we do intend to build on services in Rockville that are strong and consolidate those services that are not utilized at Manchester. And we will, as I mentioned, enhance the offerings at the Rockville's emergency department services. I mentioned how Rockville's distance from Manchester of 9 miles is not dissimilar to Guilford's distance from New Haven. And we have significant experience with this model already. When there is a need for patients, as I mentioned, that need emergency surgery, we have a great record over many years, more than I think 15, almost 20 years now, of transferring patients to New Haven from the Guilford ED. We also plan significant clinical expansions at Manchester and Rockville over time. Again, it's hard for us to know exactly every move we will make. And you can look at our track record, please do, on what we've done at Westerly, L&M, and Milford, about how we've assessed what the community need is, and then built those clinical programs according to that community need and what we are seeing on an ongoing basis. Rockville's operating rooms are ideal for using them for procedures like endoscopies or scheduled ophthalmologic or ENT surgery, and we plan to evaluate that fully. And there is a need for more ambulatory services in the area, as well as adding, as a primary care doc, I'll potentially be very interested in adding more primary care doctor access, cardiology, diabetes care, neurology, pain management, etc. Manchester Hospital, as I mentioned, does about the same number of deliveries as Waterbury. That's a very important service that we are very dedicated to. And we would like to enhance that service with obstetrical care, breast, gynecologic oncology, which we are experts in with our Smilow Cancer Hospital, pelvic floor disorders, and children's health issues. These are additions to the already strong services at Manchester that we think would really serve that community well and are excited to do so. Also, there is a growing need in Connecticut as an aging state, as our population rapidly ages, for more targeted men's health and urology and prostate cancer and conditions such as that. So in conclusion, I'd like to say, and I think you probably have seen, that I'm very excited about this opportunity to bring academic medical care, local medical center level care to the communities of Waterbury, Rockville, Manchester. Thank you. So I think I'll turn it over to my colleague. I'm sorry.
And before we do that, I am not 100% certain if you adopted your pre-file testimony because we jumped into the PowerPoint. So I just
No,
wanted
I
to go ahead. You did?
I did.
Well, let's do it again. Just to make sure.
I got my pre-file
Yeah, second.
official.
We both weren't sure.
Thank you, Dr. Balsazak. Good morning, hearing officer Chuka and the staff of the Office of Health Strategy. I'm Ann Diamond. I'm president of Bridgeport Hospital, and I would like to adopt my pre-file testimony. Thank you so much for the opportunity to speak with you today in support of the Yale New Haven Health System proposed acquisition of Waterbury Hospital and the Eastern Connecticut Health Network. I joined Bridgeport Hospital in November of 2019, only a few months after the acquisition of Milford Hospital, which then became the Milford campus of Bridgeport Hospital. And as a result, I've had the opportunity to personally witness and participate in the comprehensive and thoughtful way that the Yale New Haven Health System integrates new facilities into its system, including new campuses of the existing hospitals. I believe that the experience in Milford is a strong indication of the system's capabilities and helps us illustrate the value that Yale New Haven Health System will bring to the prospect hospitals. Now, in my pre-file testimony, I provided background information on financial stabilization, the significant capital investments, and the journey to bring Milford Hospital to clinical standardization that elevated the standard of care within the community. Today, I'm going to provide some additional depth to my written testimony and frame that transformation that happened over the 39 months. The quality of care, the pride that was displayed by the employees for their new organization, and that shift that really revitalized the trust felt by the greater Milford community to once again seek care within their hospital and the outpatient services that were now available within their community is the direct result of the effective integration plan. You're going to hear a little later in the public testimony from some long-term Milford Hospital, now Bridgeport Hospital employees, but I think Dominic sums it up the best, and this is a direct quote. At the time of integration, I had been with Milford Hospital for 26 years. Like a lot of my coworkers, I was a little skeptical and didn't quite know what to expect. What I learned is that it's been a good fit, and it just meant so much to all of us that they delivered on the promises and that Milford is thriving again. Another example of the benefit to the community includes the clinical expansion of subspecialty services, including behavioral health, ear, nose, and throat, critical care pulmonologists that are now in the intensive care unit, allergists, and geriatricians, just to mention a few. In May 2019, Milford Hospital had a very low inpatient volume, around 20 patients. Today, the Milford campus of Bridgeport Hospital cares for 75 hospital and rehabilitative patients each day. On the outpatient side, volume increased from 36,000 in 2019 to over 60,000 patients served in the greater Milford community. The Yale New Haven Health System added 100 new technologies in 100 days of the transition, including electronic medical health systems, communication systems, drug dispensing technologies, new materials trackers, revenue cycle management, digital diagnostics to take blood pressures, temperatures, and other vital signs are among the number. These investments by the Yale New Haven Health System have enabled a renewed confidence in the clinical care provided to the regional communities. That very deep connection between the hospital and the patients that they serve is stronger than ever. I have every confidence that the Yale New Haven Health System will have the same positive outcomes in Waterbury and the Eastern Connecticut Health Network. I thank you. And now next, I believe, is President Deborah Wayman from ECHN.
Great, thank you, Anne. Good morning, everyone. My name is Deborah Weymouth, and I too adopt my pre-filed testimony. And I also would like to thank Hearing Officer Chuka for investing your time and attention with your team into this valuable and important process. As noted, I currently serve as president and CEO of ECHN, which includes Manchester Memorial, Rockville General, Visiting Nurse Services, and numerous medical offices and outpatient services. ECHN sees significant value in the partnership with Yale New Haven Health System because the people of Eastern Connecticut will benefit enormously from this proposal. Just some examples of these benefits include improved coordination of care delivery, quality of care being enhanced, improvements in recruiting and retention of physicians and staff, local investment and resources, as well as the capacity to address health equity concerns we believe that will be expanded. Care coordination will be enriched due to the availability of clinical information and data, as was mentioned earlier, which will be accessible through a unified electronic medical record, EPIC. This system upgrade will benefit patients and physicians alike with simplified access to medical history, lab and test results, and medications. A connected EMR will reduce the need for duplicative tests, ensure adherence to established best practices, and automate administrative tasks, which can increase productivity and efficiency for healthcare providers. ECHN currently operates a family medicine residency program to train, recruit, and place full spectrum family physicians in our community. ECHN, working with Yale New Haven Health, will expand the current physician mentoring programs, enhance disease-specific education, and other related opportunities, resulting in physicians that would be more likely to remain local and build strong relationships with their patients. Joining a larger hospital system like Yale New Haven can strengthen employee recruitment and retention overall. There are greater opportunities for career advancement through promotions or access to training and development programs, which can increase employee and physician satisfaction and loyalty. We want to continue to retain our highly skilled nurses and physicians and all health professionals who call Connecticut home while caring for others and strengthening people's lives throughout Eastern Connecticut. Also, ECHN's return to nonprofit status will be positive, Connecticut-focused results. ECHN's operational performance will result in capital investments in our community-based facilities, technology, and infrastructure, as well as programs and services that our local communities need. ECHN will be able to engage in community members and volunteer opportunities that result in increased interest in healthcare career opportunities and will result in deeper relationships with people across our region. The expansion of philanthropic programs will also enhance ECHN's ability to sustain and provide exceptional patient care. This transaction will further address health equity issues across the state. Yale New Haven Health System has earned the Health Equity Index Award designation for its focus on diversity, equity, and inclusion. ECHN believes that our communities can further benefit from this important work by being aligned with Yale New Haven Health System. With a special focus on the unmet needs of the financially disadvantaged and underserved population, coupled with the results of our next community health needs assessment, we can develop and implement service expansion strategies that are responsive to community needs. This demonstrates our shared interest in treating the whole person and the social and economic and environmental factors that shape the health of individuals and communities. ECHN is a patient-centered, community-focused organization with 100 years, has been in the making for 100 years. ECHN's 2 hospitals and our visiting nurse and health services of Connecticut organizations have certainly stood the test of time. We are stewards of this asset to our community. Remaining a community healthcare provider while benefiting from a larger local system is the best path forward. This proposed transaction will further strengthen our ability to help people in our community with a broad spectrum of quaternary care services, including clinical trials, while remaining close to home and connected to those who have provided care for them for years. I urge you to consider the hundreds of thousands of people who reside in Eastern Connecticut and provide them the opportunity to benefit from having ECHN's hospitals and affiliated services join Yale's healthcare organization. Thank you for your attention, and I'll now turn it over to Dr. Justin Lumby, President and CEO of Waterbury Health.
Good morning. My name is Dr. Justin Lumby, and I too adopt my pre-filed testimony. I'm a board certified cardiologist practicing today and the president and chief executive officer for Waterbury Health, a role that I've held since November of 2021. I previously served as the chief medical officer for Waterbury Health for 5 years. Going back, I did my training at the University of Connecticut in residency in internal medicine and a cardiology fellowship, and since then have been actively involved in academics, as well as to continue to take care of our patients. I am here to provide testimony in support of the proposal to transfer Prospect's Connecticut assets to Yale New Haven Health Services Corporation. Waterbury Health operates 357-bed acute care hospitals serving Waterbury and 11 neighboring communities in Western Connecticut. We provide comprehensive medical services to those communities through our hospital, our outpatient clinics, primary care practices, and rehabilitation services. Our service line includes emergency medicine, cancer care, cardiovascular care, orthopedics, neurology, pediatrics, women's health, behavioral health, and many, many more. We focus on patient-centered care, community outreach, and education while employing a team of highly trained professionals and investing in the latest medical technologies and treatments. We are committed to recruiting and retaining high-quality staff, evidenced by our nurse residency program, staffing committee, and educational opportunities. Our goal is to improve the health and well-being of our patients. The acquisition proposed will help us reach this goal by allowing us to offer a broader array of services available through the support of a regionally healthcare system. The proposed transaction is expected to have significant benefit for the patients of Waterbury Health. By collaborating with a larger academic system, we will be able to enhance our financial strength and become more of a fully integrated and streamlined regional healthcare system. In addition, this transaction will allow us to transition to a single electronic medical record system, which has been addressed several times previous to me, improving care coordination, ensuring all providers have access to critical information in a timely manner, lowering costs by streamlining clinical encounters, and enhancing quality and safety through improved information management. Furthermore, existing joint programs such as our cancer care at the Harold Lever Cancer Center, neonatal intensive care unit, maternal fetal medicine, and internal medicine residency program will continue to provide comprehensive care to the community while serving as a foundation for further collaboration and other programs. The acquisition will also provide Waterbury Health patients enhanced access to Yale New Haven Health's subspecialty providers and care closer to home. As such, the acquisition will further enhance access to specialty care closer to home, ensuring that patients receive the best possible care. In summary, the proposed transition is expected to have significant benefit to the Waterbury community, including continued access to critical healthcare services for the uninsured and the underinsured. The transaction will also help maintain a strong commitment to recruitment and retention efforts for high quality staff. Lastly, the transaction will further Waterbury Health's mission and its public's best interest. Thank you for the opportunity to testify to support the Waterbury Health's application to transfer its assets to Yale New Haven Health Systems.
Thank you. Do you have anyone else that wanted to make an opening statement at this time?
We don't hear yet.
At this time, I think we're going to take a 15-minute break. Attorney Reinhardt, you and I had to go over those dockets during the break, so we'll do that. Let's come back at 10, say 10:52. So we'll start off at 10:52, and just a reminder that although the recording will stop, the video will probably still keep going, so just be careful what you say. Yeah. For those just joining us or for those coming back, this is a hearing regarding docket 22-32594. It's Yale New Haven Health Services Corporation and Project CP Inc. The transfer of ownership of a healthcare facility. Before we get back into things, I did want to mention that for those of us who are present in person, we're being asked to be extremely quiet in the hallway or have your conversations in the breakout room, which I believe is conference room 3C. Or you could speak in here as well, but there are people who are working for DPH and they need to be able to concentrate. So I would appreciate everybody's consideration in that regard. Earlier we did the preliminary presentations by the applicants and their witnesses. On break, we clarified some of the dockets for which I took administrative notice. The numbers for, let's start with Lawrence and Memorial, that acquisition, that is 15-32033. The Milford acquisition, that is 18-32270. St. Raphael's acquisition is 12-31747. And also the Prospect acquisition, I gave one of the docket numbers earlier. There is a separate one related specifically to Waterbury Hospital, which I did not provide. That is 15-32017-486. The other one that I did provide was for ECHM and its two hospitals. There was also one other clerical sort of matter that we wanted to address, and I will leave it to Attorney Reinhardt to speak on that.
Yes, thank you. The correct version of our revised worksheet A is exhibit 25 in the record. And I think a draft version was inadvertently included in the slide deck that was shared. So if anyone needs to access the correct version, it is exhibit 25 in the record, and we'll file an amended PowerPoint deck showing the correct worksheet so that it's clear in the record.
Thank you. So with that, we are going to jump right into questions by OHS staff. And I believe we're going to start with Roy. Yeah, correct. Go ahead.
All right. Good morning, attorneys Reinhardt and Volpe, and good morning, leadership team of Yale New Haven Health Systems and Prospect CT. Thank you for being here in person to provide additional testimony and for answering OHS's additional questions. So my name is Ronan Wong, W-A-N-G. I'm an associate research analyst with the Office of Health Strategy. And to begin, I would just like to ask some questions regarding the financial feasibility and strength of the healthcare organizations involved in the proposed transfer of ownership. So my first question would be, would you please provide an overview of the current financial status of each of Prospect CT's hospitals, with focus on income losses for operations versus non-operating revenue?
If it's okay, I think we would like to have the caveat coming. It was directed to both of the applicants, right?
To begin, I just
Okay.
asked about Prospect, Connecticut. Yes.
Okay, Roy, if it's okay, we'd like to have James Phillips sworn in. And Cheryl DeCilio, if they could both come forward, it's Jim and Cheryl. Maybe what we could do is, maybe, can we just pull up 2 chairs right there? That'd be okay. Thanks, Jim.
And there will be additional questions for the Yale New Haven side of this, if we want to get everybody
Sure,
on the
I think
financial
they
side.
were sworn in, if we can have them sworn in.
Okay.
Yeah.
And we kept all our financials hopefully in one section of the questions.
Sure.
So that way we can rearrange once we move on to the next section.
Dan, you want to swear? them in?
Yeah, I will. To the greatest extent possible, we're going to try to take this topic by topic. But there is going to be some jumping around a little bit. I'll first have you just state your name and your position. We'll start with this gentleman, James Phillips, Chief Financial Officer for Waterbury.
Cheryl DeCilio, Chief Financial Officer and Senior Vice President of Revenue Cycle for the city.
Could you spell your last name?
Sure, it's DE, capital CIFIO.
Thank you.
And Cheryl Williams.
Thank
you.
And were you sworn in? Sorry.
I was.
Okay. Please raise your right hand. Do you solemnly swear or solemnly and sincerely affirm, as the case may be, that the evidence you shall provide shall be the truth, the whole truth, and nothing but the truth? So help you God, or upon penalty of perjury. And please, I know we're awfully close, but please just speak up so that the camera can hear you.
Thank you. So I will just repeat the question for the new witnesses that were just sworn in. Would you please provide an overview of the current of each Prospect Connecticut hospital with a focus on the income and losses from operations versus the non-operating revenue?
Are you looking for specific numbers or just a general?
I think general trends or any major changes or shifts in the recent financials.
So for Waterbury Health, recently it's on their 22 lost operation, bottom line loss. And we're going to still continuing to experience losses currently this year, which is 6 months.
ECH and similar results. The losses in 22, 23, we've seen a little bit of uptick, but we do not have a full turn.
And
Would
we
you
just
speak up a little bit?
Sure.
But if both of you can speak up.
Sure.
I'm sorry.
so for the ECHN hospitals, would you discuss a little bit more about the non-operating revenue losses and what that entails?
So for non-operating revenue, we have a lot of our joint ventures fall within our non-operating revenues. Those losses from operations obviously were affected by COVID. So a lot of those non-operating losses come from those joint ventures.
Okay. And then broadly speaking, we can do it for the system and then also for each hospital. What would you identify as the root causes of the financial struggles, as you kind of mentioned?
A lot on the expense side. I mean, COVID brought a whole different level of expenses. So all organizations, all hospitals across Connecticut, with increased inflation, mostly on the wage side. That's really what we're experiencing, as well as the rebound in volume. Patients still struggle to return to the hospitals, return to some of our outpatient facilities. Those were, I would pinpoint as the major focus.
And same for Waterbury
Take the
Hospital.
Waterbury, the cost of labor is very dry on the expense side. Having to use contracted labor because we're having difficulty filling positions, that's been an issue.
Sure. And just to break apart kind of the time periods about the financial issues, would you mind clarifying if these issues have been the same since the acquisition of the hospitals by Prospect CT during COVID and peak of COVID, and then versus present day? Have there been any shifts to these root causes of financial issues?
I would say that the issues came up during COVID, not necessarily from the onset of Prospect acquiring Waterbury, but definitely from COVID onset forward, and then coming out of COVID, more so with the inflation and wage growth was more post-COVID.
Sure. So moving on to the financial status of Yale New Haven health systems, pardon me. Would you please also highlight the current financial status and please provide a focus on, again, the operational incomes and losses versus non-operating, if those are different, and please focus on any of the prior or recently acquired hospitals, such as Virtual Hospital's acquisition of Milford Hospital, L&M, or St. Raphael's.
Sure.
I'm
Well,
sorry, your name again? I apologize.
yes, I'm sorry, Gail Kosla. Thank you. Yes. So in 2022, the health system reported a loss from operations, about $300 million, and also a loss from non-operating of about the same, for a total loss of about $600 million. Within the operations, we don't include things like investment markups for the market value of those investments, or markdowns, if you will, as was the case in 2022. It was a tough year from a market perspective. In 2023, we're experiencing a similar loss. About $250 million is budgeted for 2023 from an operations perspective. The markets have rebounded somewhat, so that mark-to-market impact in 2023 is better than it was in 22. I would cite some of the same reasons for the operating loss. We have expenses outpacing revenue growth at this point in time, mainly due to the shortage of significantly important physicians. We have a use of labor that is outside of the organization, contract labor we're using, and the revenue growth has not kept pace with that. Also, inflationary factors are affecting the supply chain, things like of that nature, malpractice insurance, et cetera. We have a strong mitigation program that we put into effect. If you recall, 2021, we were getting a lot of dollars from a COVID relief that helped offset some of those losses. And now we're at about the same or a little bit better without the relief funds.
Thank you. So with the overviews of the two systems answered, how does the Yale New Haven Hospital system propose to address Prospect CT's financial issues as outlined? And please also highlight any solutions that worked for prior acquisitions as examples.
Sure. As we look out and project into the future, what our planned initiatives, which, as I understand, were what took place prior to my arrival with the acquisition of the other organizations, was really looking at efficiencies in the way that we operate. Those are really factoring into the greatest amount of what we call synergies. So we're doing the best we can to estimate how we would potentially operate under the scenario where the hospital's part of the system. And so looking at synergies, supply chain costs, mainly or help us to achieve a near break even by 2025.
Okay, thank you. The next questions are actually derived from Mr. O'Connor's pre-file testimony on page 1485 and 1486, where he describes some of the benefits to St. Raphael and Lawrence Memorial Hospital after joining the Yale New Haven Health Systems. So my first question, and it can be to you, Mr. O'Connor, or the finance team here, how are the total cost savings of $638 million at St. Raphael and $46 million at L&M from the merger calculated?
If you want to refer.
I understand.
1485 and 1486.
Correct.
Base same.
Yep. believe the first paragraph is regarding the benefits of St. Raphael, and the second page has the info similar for LNF.
So those costs would be related to functionality that we were able to gain greater efficiencies. I mean, perhaps some examples might help. I think that looking at the way that certain back office functionality works, we can consolidate those operations so that we create greater efficiencies. We also, by being on the same platforms, we can help reduce costs associated with running different systems. We also have vendors that are common across our health system that we can help get better pricing because of the implementation costs.
Okay. And was the similar methodology that you just kind of described for calculating those savings applied to the financial projections in the event that these hospitals were required? And then of those components, which would you say contributed most to each hospital's savings and or their positive financial performance? For example, I believe in Mr. O'Connor's testimony, he mentioned that L&M's positive margins in 2020 or L&M experienced positive margins in 2021, despite the financial challenges posed by the COVID-19 pandemic.
I would have to look back at the details to see where the specific things were, in terms of the projections for this. Again, as I mentioned, those process improvements really are where we're looking for the opportunity. So I'd have to go back.
Sure. Here in Ostrajuga, may I request that as a late file, just to have the breakdown of the savings? Sure. And then last question related to that is, do separate financials exist showing the contribution of the acquired hospitals versus affiliations to the overall financial stability and savings? Are they separated, or is it all?
Contribution margins for the.
Yeah, the contribution of the hospitals versus the affiliations and joint ventures to the overall savings that were experienced by St. Raphael and L&M.
I would have to look at that.
Yeah, they are. So for the hospitals that were integrated, so St. Raphael's and Milford, they're fully integrated into Yale New Haven Hospital and Bridgeport Hospital. For L&M, it still stands as a standalone, so those are separated financials.
Okay, so then I guess in the late file of breaking down the savings, if there are financials that exist for teasing apart any of the joint ventures versus the hospital itself, that would be greatly appreciated for that breakdown, just to visualize.
It's in our audited financial statements, the breakdown of the individual entities is in the audited financial statements. Do you want to say something?
Okay, thank you. My next question is, as both Mr. O'Connor and Ms. Diamond shared in their pre-filed testimony, the integration of Milford Hospital as a campus of Bridgeport Hospital in 2019 represents another example of successful integration of a hospital in quote dire straits. This is pre-file testimony of Ms. Diamond on page 1495. The question is, please explain the reported loss for operations of 16.3 million experienced by Bridgeport Hospital in 2020, and then the net positive income and revenue in 2021, and then the net negative 31.7 million deficit in 2022.
Are you looking at, is it total income, or is it the just from operation?
This would be net deficit. Yeah, total.
Yeah, so I would say similar to the explanations that we gave there. So in 2020, we were receiving COVID relief funds. There were gains from the investments in 2021. That was 21, 22. We're also seeing losses from investments. So the same would fall true for Bridgeport.
Sure.
In 2020, during the height of the pandemic, volumes were significantly lower as we grappled with outpatient services, elective services, and not seeing the non-patients that we've seen in the past.
Okay.
And then struggling with the same expense categories in our same contract. Supply chain.
Thank you.
We didn't furlough any of our employees, so they maintained their current employment through the shutdown as well in 2020.
Okay. I will pass it along to my colleague Bojana, who's going to continue on with some financial questions.
Good morning, my name is Bojana Piastri. The spelling of the first name is Bozena. Last name is Piaskik. I'm an associate healthcare analyst, and I was worried that I'll continue with the financial disability and strength questions. This has to do with regarding for prior transactions involving affiliation of T-Mobile Hospital, the Bridgeport Hospital, and the transfer of ownership of Lawrence and Memorial Hospital. My question is, what was the process for implementing the Yale Health System's financial and accounting practices of the newly acquired hospitals, and how long did the process take?
So for each of the hospitals, we implemented, well, let me take you first from St. Raphael's. So we actually used a third party during the St. Raphael's integration. And then we transitioned to our internal resources for both Lawrence and Memorial and Milford. So in that process, we go through a full integration planning assessment. I think, Tom, as you mentioned in your testimony today, that we don't have full clarity until the close, because there are a number of pieces of information that are just not available until you actually close on the transaction. Once that occurs, our team goes into full deployment. They begin to do an assessment phase. We create gaps between what we are currently doing within the health system and how we and what's going on at the newly acquired entity, and begin to prioritize what are those. And they're different depending upon the state of the individual organization. So for instance, we did not convert our supply chain systems in Lawrence and Memorial immediately, because we were going through a full system-wide upgrade of our enterprise management system. So those are things that are determined based upon a case-by-case basis and evaluated by the internal team.
So would you be able to give me an idea of how long did these processes take? At least I understand it's progress from one to another, but roughly do you have a timeline that they usually
We
takes?
try and get the majority of it done within a year. I think if you look at the year horizon, but depends. Epic, as was mentioned earlier, is the backbone of the clinical systems. And then we evaluate the other systems based upon the needs. But we try to move through that within a year, 18 months, to convert those systems over to the systems we're using across the system.
Great, thank you. My next question is, the applicants described the New Haven Health System partnership and migration plan in response to question. It's 10A of OHS first completeness letter. It's in pages 1048 to 1050. We'd like to just look at it for a minute before I.
What do you mean?
It's in the first completeness letter. It's pages 1048 to 1050. Yep.
I'm really impressed with the fact that you all are all paperless, right?
We have buttons. They are sitting there.
But yeah.
So you're referring to fire. Okay, which, so the question is. Mike, what's the title?
Yeah.
It's not much. 1040. You can repeat that number.
Sure.
And the number of the question.
The question is 10A, so you just correct it when you're referring to the questions of the planning.
Okay.
But this is regarding your response that there is within that response of that question 10A. And that's when your question is going to come in. So you're only going to.
Is that 10A?
If it's
Let me get
helpful,
the
that's
question.
Yeah.
exhibit F, in the table. Want to make sure you're looking at the right back.
Yeah, I'm just looking here.
Okay.
We haven't done it.
Yeah, I'll be happy to.
Is the question on the 5-year plan and mitigation?
The mitigation.
Okay.
So my question is, has this plan had any impact on current financial results or any of the projected results indicated in revised worksheet A, exhibit 23 for Yale New Haven Health Systems or any of the affiliate hospitals?
So if you were referring to the, I'm just trying to find the reference to the.
It's the last paragraph of the response on page 1049 that begins with Yale New Haven Health System, however, has a long track record, and then it goes through kind of examples of the mitigation plan.
Yes.
That paragraph.
Yes, so to the extent that items have been implemented and are reasonably expected to be implemented, they were included in the 5-year projection.
And this part of the question is, can you provide statement of operations for Yale New Haven Health Systems and any affiliated hospitals showing 6 months year to date as a link file, please?
Can you repeat the link?
6 months.
Statement of operations for Yale New Haven Health Systems. Wait, thank you so much. Do you want to my next question?
Yes.
My next question is, regarding the applicant's response to question 26 of OHS first completeness letter, page 1058. So we're still in the same section, just in yourselves, which stated, it is expected that the current negative operating results of Yale New Haven Health Systems will continue due to the factors above and the significant investment needed in estimated and IT facilities. I apologize. And IT, and the restoration of services and other measures will be required to migrate the losses. My question is, what is the significant investment needed in the facilities and IT? That's my first part.
So with respect to the IT, it would be the integration of the Epic system.
Okay.
Okay, any other systems that once we determine aren't compatible with the integrations of the health system, that would be included. There's also this facilities review to ensure that they're meeting the safety needs of the patients and that we can continue to operate in those facilities. So there are placeholders for facilities. And I don't know if any of my other colleagues have any information. Other investments then, but
I think the biggest is Epic coming in. Yeah, so we submit one.
If you would like additional details specific to Epic, we have someone who can directly answer IT and Epic related questions.
Sure.
Hi.
Hi, so just specifically said that.
She has not been sworn in.
Oh,
We should
yeah.
find out her closer.
Yes.
I was sworn in this morning.
Oh, yes, you were.
This is Lisa Stone.
My
So the other investments in IT extend beyond Epic as well. We will invest in the cybersecurity and underlying network infrastructure, the connectivity, the wireless infrastructure to support the healthcare environment that we envision. Epic being one piece of that, but as my colleagues have mentioned, we will implement other core platforms that operate our business, our human resources systems, our general accounting systems, our procurement systems. And then again, that underlying infrastructure, the network capabilities and cybersecurity are some of the major beyond that.
My part of this question, so the next part is, can you please clarify and provide examples of the additional of services and other measures involved in mitigating future losses?
I didn't catch the first part. So,
if you can please clarify and provide examples of the rationalization of services and other measures involved in mitigating future losses.
So with respect to services, yes, Dr. Balthazar, you could respond to that.
Sure. So again, I mean, our clinical services plan, as we mentioned, is not yet complete. It's a lot of work for us to be able to complete that plan. We expect to do that within 6 months. I can give you numerous examples of how we've rationalized services at both the Milford campus of Bridgeport Hospital or Lawrence Memorial, Westerly, and St. Raphael's campus. In each one of those circumstances, we did not have a plan prior to the close of the transaction. But we undertook that plan rapidly after the close and we instituted it within 6 months. This is a continuous evolution of process. And we have continued to evaluate those. We always do that on an annual or frequent basis of what services we should provide where. It depends on changing demographic, patient need, community need, et cetera. We did say already, one of the rationalizations we are asking for at the close is a single license to operate the Rockville and Manchester Memorial Campus under a single license. And we will anticipate closing the inpatient med surg service at Rockville and moving those inpatients to Manchester. It's neither safe, effective, nor fiscally responsible to operate an average daily census of 3 med surgical patients. And that's a small example. There's not substantial savings there, but I think it's one of the very first and one of the ones that we see already that we think is appropriate in terms of the rationalization service.
And some of the other factors to help mitigate the loss were what I described earlier, when we talked about process improvement, economies of scale, and trying to with implementation of our IT platforms to enable some of that functionality to be offered across a greater breadth of facilities, mainly outpatient facing activities.
Thank you. I'll go to the next question. In the original worksheet A, page 743. It was, I'll just pull it up. Yeah. So it's the original worksheet A.
It's trying.
That's supposed to say.
We all have papers. It was projected that Yale New Haven Health System would have a loss from operations of 72.6 million and 112.3 million for fiscal year 24 and fiscal year 25 respectively. My question is, in worksheet A, it was projected, in worksheet A, page 743, it was projected that Yale New Haven would be a loss from operations 73.6 million and 112 million for fiscal year 24 and 25 respectively. And in the revised worksheet, exhibit 25, you'd like to pull that up.
What's the date stamp on that? On revised,
25.
Was sent in as a separate Excel sheet
Excel document.
as part of the response to the first convenience letter, so it doesn't have. a-
It's just exhibit, yeah.
6
I think there's also, it was also done as well, grade number 1295. It would be. We did both because the Excel is here. So used to be.
Oh, okay, thank you. So in the revised exhibit 25, the projection changed to 36.7 million and 9.5 million for the fiscal 24 and fiscal year 25 respectively. My question is, can you explain the significant changes in the projected incremental amounts between the two worksheets?
Sure, couple things. So first was that we did identify a modeling error in the first document. That has a significant double
Correct.
impact. We were calculating the increase on the increase versus the total. So it sort of multiplied and then became exponentially larger in the out years. That is the number one item. We also had, there was the state's Medicaid rate settlement, and we inadvertently forgot the rate increase that was part of that in the first model and added it to the second model. We also, we looked at the asset purchases identified and the depreciation associated with the assets purchased. And we were using an average life that was consistent with the typical IT acquisitions, but certain items like the Epic install have a life that is much longer than the recommended depreciable life. So we reduced the depreciable life on that, and that expanded the number of years over which we depreciate the asset, lowering expense. We also incorporated, we had updated financial statements from Prospect that we updated and included in that. We also modified some of our synergy assumptions as we got more information. We were able to test those to a little bit greater degree. The largest by far was we also moved the cost of capital. We had previously put that in the interest expense. Since we would be financing this potentially with cash, we recognize that in the non-operating piece instead of in the operating. So we moved that below the line.
Okay.
Can I ask a quick clarifying question regarding the Medicaid rate increase that you mentioned? Are those increases part of the prospect projections now as well?
They're in the column that's in the incremental.
Okay.
It was in that the changes were made.
Yeah. My next question is, can you please submit as a late file the final version of the fiscal year 2022 audit financial statements for all 3 Prospect, Connecticut hospitals and non-hospital entities that have a IS plus audit financial statements? And it is understood that there's an extension that was granted to Prospect for till May 1st.
I'll leave that to my Prospect colleagues.
Correct.
Okay.
Yeah, there are letters on file. Jim can speak to that. In terms of the extension.
It's just that there was extension that was granted till May 1st, so we're just asking for a late file if we can have the financial statement 22 for Prospect.
Yes.
So you don't expect to seek another extension, is that? correct?
I'd have to confirm.
Okay.
with my client.
Okay, we can work out timing on late files, but
Yeah, I mean, we've been diligent in seeking extensions early on and timely. It's in the file. And I think.
I
we'll
wasn't
get-
asking you to commit to like a time frame. If you need to do another extension, I'll leave that to
Okay.
HRS to deal with.
All right, thank you.
I was just looking at it from the perspective of, how would we work that with the late file timeline?
Understood, and we'll try to get a good estimate on the audited financials for the 3 hospitals for 2022.
Thank you. I was questions of Mr. Steve and.
I'm gonna switch. My name is Steve Lazarus.
Sorry, not to
Okay.
interrupt. I did just want to say, we are going to be skipping around some more, so just because we've gone off before and gone up before John, there are more questions. So, don't think you're out of the woods.
All right, so again, my name is Steve Lazarus, and the following couple of questions have to do with more with accessibility parts of that. So the pre-file testimony of Ann Diamond described the increases in the inpatient discharges and increases of the outpatient volume at Milford Hospital following its affiliation with the Bridgeport Hospital. My question is, were these increases to the existing inpatient and outpatient services, or were there changes to the types of inpatient and outpatient services provided at Milford Hospital in the years following the acquisition?
Good morning.
Good morning.
Yeah. I think the finance people are happy. Awesome, thank you.
Your name again, I'm sorry.
Ann Diamond, and with an ADIA MOND, President of Bridgeport Hospital. So the increase in the inpatient and outpatient volumes occurred because we were able to add different specialty services to both the inpatient and outpatient service offerings. For example, there is a 10-bed intensive care unit at Milford Hospital. It did not have neurological specialty services. It did not have psychiatry. We added teleneurology. We hired pulmonary intensive care physicians to be physically on site. This enabled us to admit patients that would present at the emergency department of a higher acuity than would have able to been cared for safely under the Milford Hospital code.
And what was the timing of that one after the post transaction? Was it 1 year to 18 months, or was it something that was like gradually over a 3 to 5 year period? Can you talk a little bit about that?
Yeah, sure. So in the integration period, there's really 4 phases that Yale New Haven Health System uses. The first 100 days is what we call a stabilization. It enables us to go in, look at the clinical, the support and ancillary services, ensuring that there is safe care happening. And so examples of that would be transition to the employees from Milford Hospital over to Bridgeport Hospital and Yale New Haven Health System. The standardization then took place at that 6-month timeframe. And that's where you heard from Ms. Stump that we brought in the EPIC system. And by doing that, that enables clinical pathways, or what the lawyers think of as a standard of care, to be able to be implemented. And Dr. Baltazak spoke to that. That also has cost-effective outcomes in a positive way. There's not duplications of tests, et cetera. So that happens during the standardization phase. Then between the 7 and 24-month phase, we look to optimize. That's the opportunity to really understand from the community what the needs are from a clinical perspective, and increasing our local access. Again, planning and working with our colleagues and partners at Yale School of Medicine, the Northeast Medical Group, we were able to figure out who else do we need to bring to the community in order to improve that access. And improving the access thereby increase the volumes that you're asking.
May I add 2 things?
Yes, of course.
Anne mentioned the opening and expansion of the ICU services. That could not have been possible, as Anne mentioned, without the recruitment of a critical care pulmonary physician. Problem is that leaves that unit only covered for those 8 hours, 5 days a week that pulmonary critical care physician can work. We were able to augment that coverage through partnership with the Northeast Medical Group and the Yale School of Medicine, as well as install our tele-ICU system. So although there is no critical care intensivist on campus, there are critical care intensivists caring for those patients 24/7. That is the standard of care right now, but it is not present in most US hospitals. Most US hospitals do not have an in-house critical care pulmonary physician 24/7. There simply are not enough physicians in the United States to provide that service. But one of the things after the installation of EPIC, after the installation of the electronic backbone that Lisa Stump mentioned, we were able to put that camera, microphone, et cetera, in every one of those rooms. So those patients have that benefit. The physicians and community that care for those patients are then comfortable with that care, so they can stay in Milford Hospital, whereas before they would be transferred out to either Bridgeport or New Haven. The second thing I would say is both Bridgeport and Yale New Haven were quite capacity constrained at the time of the acquisition of Milford. And we saw that one of the areas that we had, which is a prospective payment system exempt unit, which is our rehab unit. Each of us had a PPS exempt unit for rehabilitation that had an average daily census that was only about half of an inpatient unit. We consolidated those 2 rehab units at Milford Hospital and were able to decant those subacute patients from both the acute campuses of Bridgeport and the acute campus of Yale New Haven and bring them to the beds at Milford Hospital, immediately increasing that census and importantly, opening beds at Bridgeport and Yale New Haven for the more acute patients, which were desperately
And if I could just add, the 4th part of the integration process is Thrive. And that's really where we are right now. So the Thrive occurs between the 25 and 36-month timeframe. And it was during that timeframe that we really brought additional specialty care. For example, all of our nurses and physicians within the emergency department of the Milford campus have special certifications in geriatrics. And then we expanded that to some of our inpatient units also. So that's just one example of continuing to find validation through external benchmarking and through external certifications. That was not present at Milford Hospital. So that's really part of the integration process. So it's really a very defined, highly reliable four-phase process as we take on these new hospitals. And I would see us following something very similar.
Pile on again, but in addition to the geriatric side of the
It's my
certification.
tag team.
It's triggering a memory. The geriatric certification of the nurses, we also received because Milford has a particularly aged population. And so we saw geriatric certification of the entire emergency department.
Yes,
And we've seen a subsequent increase in local residents, particularly geriatric residents, using that ED in Milford rather than traveling the 9 miles to Bridgeport or I think it's 11 miles to Maine.
that was part of that reviving the, the community's trust in their local hospital.
So following that model, was that also what was followed in L&M? And can you speak a little bit to the L&M experience and the transition there as well? And it's same type of, if you saw same type of increases in utilization there as well, and was that as a direct result of this four-phase model?
So I'll jump in and on the Lawrence Memorial integration. Remember that also included Westerly Hospital, which I know was in it's within the scope of OHS, but we ran both of those hospital campuses as a single unit. We did the same process that Ann described wonderfully in terms of first stabilization. In that case, we had a late understanding of the losses that were being borne by the system at that stage. It dropped significantly to negative $27 million, literally from our understanding in September to close. Or with close, I should say. So we had a pretty acute focus on that in terms of managing the financial losses. Again, same process that Ann described, going in, assessing where the opportunities were, where the gaps were. Began immediately to assess clinical programs that would be able to be either expanded, for instance, neurosurgery. They're having difficulty hiring a neurosurgeon into that geography. Working with our partners at the Yale School of Medicine, we were able to enhance that program very quickly. Cardiology was also high on the list to support and build. So each one of these acquisitions has a unique story, and you don't really learn it till you're in during those first few months in terms of where they struggled hiring, because we're not obviously allowed to know that now as competitors, and where the opportunities are. And then, as Ann said, you look over time. So it's first fight the fires and then rebuild. And that's what we have done consistently. And, again, each one of our acquisitions, I think it's in our testimony, has shown an increase in the utilization of the campuses, an increase in employment in those facilities, and an enhancement overall to the services.
And that was the same approach that was taken with St. Rayfield's?
Same approach. St. Rayfield's was a little more unique because the campuses were only 8 blocks away from one another. We also had some management efficiencies that were able to be borne out immediately upon the close of the acquisition. So there were some synergies that were, just by nature of this proximity, that happened very quickly. And that's what drove the $600+ million number, or part of it that drove it.
The innovation was mostly for putting this, assessing, using the similar four-phase model and sort of going against.
Same process. In that case, again, each one has a little different story. In that case, the York Street campus was busting at the seams, and the St. Rayfield's campus, we had shut down multiple units because of a lack of utilization. So we were quickly able to manage programs, move things like both hospitals did open heart surgery, consolidate that onto the York Street campus. Craniotomies consolidate to the York Street campus. but we could enhance and grow the med surge capacity at St. Raphael's almost overnight. In addition, a few months into the process, again, we looked at transportation. We implemented a capacity command center that managed that on a minute by minute basis proactively versus what we were trying to do initially, which was much more manual.
So switching gears a little bit to the current project and looking at Prospect and looking at the current bed utilization. Can you talk a little bit about that and how is that being assessed? That you require what more?
They want to answer.
So again, as Tom said, we can't undertake that process because we don't have full line of sight in terms of the clinical detail that we would need to fully understand where those opportunities are. So what we can look at is publicly available data. That's not very helpful really in determining what exactly we're going to do. And it hasn't been historically when we've looked at these other transactions. So we wait upon close to fully understand where those opportunities are. We do a clinical assessment with our service line leaders and clinical leaders across the system and the school. And then we make determinations in terms of what to prioritize and invest in quickly.
So has Yale assessed at least the current capacity at Prospect hospitals, at the Andrews Hospital, what the capacity might be and what the utilization rate is, and would all those beds still be needed post?
So we actually think we can grow services, and that's I think it's in our worksheet A in terms of what we are seeing at a very high level without detail. But using our experience over those last 3 acquisitions that we've spoken about, that we've put in some assumptions in terms of growth, we anticipate that we will have similar success that we have experienced at those other transactions within both the Waterbury and ECHN communities.
Moving on to
Steve, sorry, before you go on, so to capture all the kind of changes in utilization, we would hope to get provide the inpatient, outpatient, and affiliated service lines, including CPT codes and volumes for the various acquisitions, pre-acquisition, 1 year post-acquisition, and 5 years after the acquisition as a late file, just so that we can capture
Yeah,
Is that for the prior acquisition?
the prior acquisitions.
I think we would have to talk internally to know whether
Please, yeah.
it's feasible. Can you just repeat the specific elements you're looking for?
Sure, so I think just to explain the intent of getting the information is to,
Yeah.
You've described a lot of the benefits and increases, but we just want to see to what services were the largest, increases captured or where patients
If you
utilize
take
those.
Milford alone, for instance, I mean, that is an extraordinary amount of information that you're asking for. I mean, if we could use one transaction as an
One
example,
example would be great.
Sure, yeah, one example.
is that
Readily
feasible?
available. Let's go with Milford. Yeah.
Milford, yeah, okay.
Milford is nodding. Hopefully that means.
Yes, except it's been 3.5 years, so
Sure.
we don't have that 5-year.
That's okay, yeah.
But that's subsumed under the New Haven, the Bridgeport
Oh.
Hospital license.
so perhaps we could use L&M.
So that I'm concerned that we may not be able to separate out because it's billed out as Bridgeport Hospital.
No, there's a side service.
There is a site of service, we
There's
should be
site of
able to
service.
do that, and through our independent monitoring, we did
We
that
had a
right up
report
until
on it.
a few months ago, so.
I guess the one question you said before the acquisition, would we have data from?
We have
before the-
limited data prior to the acquisition. We have some numbers. I do have them with me. Maybe we can confer and.
So we may not be able to provide the full requested information for the pre-period, but we'll do the best we can.
And you were looking for inpatient, correct?
Inpatient, outpatient, and any affiliated affiliations that may. So the intent is to see where they were before, what were the impacts of being part of Yale New Haven, and then what are the long-term impacts of being part of Yale New Haven.
Inpatient DRG.
Yes, inpatient, yes, and then outpatient, CPT. does.
I do just want to interrupt, and say a couple things. For the benefit of the people on Zoom, please just try to identify yourself before you speak. And the other thing related to that is there was just a lot of like people speaking over one another and nobody was identifying themselves. So it's probably pretty hard for the court reporter to figure out who was saying what. And that includes OHS staff too. So please try to sort of slow down, and I'm not trying to, quash collaboration in terms of discussion, but I think that would be helpful.
Steve Lazarus. So Yale New Haven system had stated that the initial plans are to maintain existing services at the Prospect, Connecticut Hospital. How will Yale system improve access to these existing services if you're keeping the existing services safe?
So Chris O'Connor, I'm gonna turn it to Tom Balsazak to speak to that.
Thanks, Chris. I mean, most of the services that are currently delivering services in those communities in Rockville, Manchester, and Waterbury are really essential services and basic services: medicine, surgery, basic cardiovascular disease, gastrointestinal disease, newborn care, maternity care, et cetera, et cetera. They're really foundational to community-based care. And we really think that those are important. I would also add behavioral health to that, and the behavioral health crisis we are in across the United States. These services that they are providing right now are also absolutely critical and likely will also need to be expanded. Emergency services, primary care, all of those services that we said we were going to continue are really basic, very important services for those communities, and the services that they're using. The volumes that you're seeing are evidence of their health. 1,000 births, more than 1,000 births in both of those institutions is a very healthy maternity service, and it must be maintained. And for each one of those births, a certain percentage of those need newborn special care. High quality maternity care is linked to high quality neonatal care, and they both have great programs that we think we can build on and continue to stabilize and grow. Where we think that there are opportunities is in some other services where patients may be driving by or transferred outside of their institutions, to be able to repatriate those patients into those communities where they can receive care there. We mentioned an example of Milford Hospital and our use of tele-ICU for expanding the ICU services. We know that ICU care is one of those services across Connecticut where we receive transfers. Hartford Healthcare, other large organizations, we just receive patients from other institutions. If you're able to bolster care in the community, you can keep them there. With regard to subspecialty care, there's lots of opportunity to do enhanced services to keep those patients in those communities as well.
How long, as part of that 4-phase thing, how long would that, after you go in and do the assessment, would you have some sort of plan for services at the Prospect hospitals?
As we discussed, I mean, we begin developing that plan immediately, and we would have a version 1 of that plan within 6 months. That's not where it ends. I mean, the medical care continues to evolve, the kinds of services we can provide, the technology necessary for those services. It's a never-ending process. So we would have an initial plan by 6 months, but then that plan would get refreshed on a regular basis in conjunction with our service line executives, our partners at the School of Medicine, and what the community needs are.
Based on your past experience with recent affiliations, what were some of the most impactful strategies implemented when the hospital were acquired and services that were stabilized that helped to actually increase patient census and improved outcomes?
Chris O'Connor, pass it to Tom again.
Sure. So, I mean, we mentioned some of those. I mean, teleservices, we have, I think, nationally gone relatively slowly on. But we are at the cutting edge, and through COVID, we showed that there's a lot of opportunity for us to enhance those services. Already, we provide tele-ICU services, teleneurology, and telestroke to all of our health system hospitals. And those are very important services where those patients have an extremely high acuity. Minutes are absolutely mattering. You can't wait. You can't make decisions in the fullness of time. You must make them immediately. And teleservices allow that to happen in patients where who have a stroke, for example, minutes make the difference between a full recovery and a devastating neurologic loss. Putting those services in, again, take time because we need to put in the technological backbone. Assessing services in some of our other institutions that we've acquired and integrated. We were talking about L&M, for example. There are numerous more examples at Lawrence and Memorial. So, for example, we noted that there was a large movement of patients with prostate cancer from the New London area into Rhode Island and Providence. We were able to effectively recruit a very high quality Yale trained prostate surgeon to New London. And now we see much more of that clinical care delivered prostatectomies in New London in an extremely high quality way. How did we know that? Because we already had the radiation oncology services that we were delivering. We were seeing lots of patients that were getting their surgeries in Rhode Island, yet they were getting their radiation in New London. And we heard from those patients that they would prefer to have their surgery if we were able to provide it in a high quality way with a high quality surgeon in New London. So we actually pursued that, and now those patients are able to get probably, I'll modestly say, better care closer to home.
Chris O'Connor, just to add on to that, and those types of services include investments like multi-million-dollar robotic, and we've purchased multiple for both Westerly Hospital and Lawrence and Memorial. So it's not just the physician, it's all of the wraparound services that are essential to deliver that in the highest quality of way. So that staff, equipment, and obviously the provider.
This is Ann Diamond, if I could add to that, a perfect example for Milford that really bolstered the community confidence in our emergency department was adding some high-tech imaging equipment. So for example, there was a CT scan that was, I think, over 20 years old. It was, I think, a 3 or 6 slice, not capable of doing a head assessment if a patient would be presenting with a probable stroke. We have replaced that. We now have a state-of-the-art 64 slice CT scanner in Milford's campus. And so that's one example. As EMS and the patients are self-selecting about where they bring the patients, those are the conversions then into inpatients. So that's certainly, there's a direct connection there also.
Thank you. On page 490, Dr. Thomas, Bill Chick. 1490. It describes the deployment of substantial number of specialists from Yale Medicine, to L&M after the 2016 affiliation was approved. Can you please describe how many of these types of specialists would be deployed, for how long were they deployed, and how did Yale New Haven Health Services system determine which specialists were needed, and where the physicians eventually were they eventually recalled, replaced, or did they remain in the L&M community?
Thank you. The deployment means they're permanently deployed there. Chris mentioned, I just gave an example of a Yale Medicine trained and now Yale Medicine employed prostate cancer surgeon who was deployed there for a very specific reason, which is patients leaving the New London area for prostatectomy, yet needing follow-up care, radiation therapy in that community. So that's one example. Another example Chris mentioned, which is there was a single one neurosurgeon who was on 24/7, 365 at New London for years before we acquired that individual. That individual also known to us, and because that individual had an overwhelming number of patients, many of those patients were referred out of the New London market elsewhere for their follow-up care. So we were able to bolster with Yale School of Medicine neurosurgeons that were recruited specifically for that market to care for those patients. So for that individual neurosurgeon working there, who was working so hard, it was personal relief, but for the patients in the community in New London, they have access to much better integrated care in neurosurgery.
Can I jump in, Chris O'Connor? I think what's important is the philosophy behind this. So initially in that stabilization mode, I'm worried about the use of the word deployment. Because we do utilize faculty physicians from New Haven and the Yale School of Medicine in a short-term gap period. But the overwhelming opportunity for us is to put physicians in those communities where they stay, they build practices and relationships with referring physicians. So it's not as if folks are getting on 95 and driving down to London from New Haven routinely. In fact, we do that to stabilize those programs if necessary. We had to do that in areas like OB and other things, which is great because we have the armament to go and help do short-term needs and put Band-Aids on those types of things. But overall, our success has been seen in recruiting specific physicians for those geographies. Now, the benefit is we have the ability to do things like give them a day of academic work in New Haven. So they can go from New London to New Haven to do some academic work that they wouldn't be able to do if it were Lawrence Memorial Hospital before the acquisition.
Thanks for pulling me out of the weeds, Chris. I want to give one more weedy example to your point of this is not a deployment, as Chris said, where, beyond a short-term need that we would send someone there part-time. Another example is the OB service. There was not a midwife service to augment the local obstetrics care at Lawrence Memorial prior to acquisition integration. And we were concerned that the standard of care, like ICU, is the presence of more highly trained individuals for more of that patient's care. The historical care for obstetrics was the mom to be would come to the emergency department, be admitted, and that obstetrician may come in from their office to deliver that care. We actually modernized the model at Lawrence Memorial and brought midwives to cover for those patients while they were initially admitted. And we also augmented the coverage model for the obstetrical service. So it both supported the community OBs, plus it added an additional layer of protection, which brought the obstetrical care, we believe, in that market up to a really, I think, a national benchmark.
And the midwives that were brought in, were they employees or contracted by the system?
Employees.
They were employees, okay.
Yes.
And they were certified?
Yes.
So taking that model now to the Prospect Hospital, what is your initial assessment of what should the initial needs be for specialists and stuff for the first, right after the acquisition, for example?
Great question. I would ask me in 6 months.
So that initial assessment has not been done. That would be part of the phase one when you would go in and do the assessment.
Exactly.
We've been going for over an hour now. I do think we'll take a break in a few minutes, but I wanted to get through a few more questions before we do that. That work for you, Steve?
Yeah, that's good.
And then, my plan is to take lunch probably around like 12:45, 1 o'clock.
Steve Lazarus again. The following question is based on the pre-filed testimony of Mr. O'Connor's. Date stamp page 14/18/84. It states in there that over time, we expect Yale New Haven Health Services reputation will allow us to recruit additional physicians to those regions. Can you please discuss and provide evidence that Yale New Haven Health System's reputation advantage in physician recruitment?
Chris O'Connor again. Well, it goes back to the example that I just cited. So I think that one, the Yale brand carries some weight, and we have had success in just merely after an acquisition, if we're looking for a subspecialist, to be able to recruit for that subspecialist, whereas formerly, if they were a single physician and subspecialty practice, that puts an enormous burden on that individual. We can bring a cadre of individuals to help support that program. So that's one. Two, I think the brand itself has value and has proved to be quite helpful in recruiting physicians. But it goes back to the as an academic health system, that example that I used earlier of if it's an individual's interest to pursue some academic portion under the community hospital models, they would have no avenue to support that work. Because of our affiliation with the Yale School of Medicine and Yale Medicine specifically, we've had the ability to offer for those physicians. In fact, one of those was the urologist that Tom was mentioning, had training at Yale, had a strong connection, would not have come if it was not part of the Yale New Haven Health System. So, I think that's the success that we have seen historically. We would anticipate similar success in Waterbury and in the CHN communities. And ultimately, we feel very strongly that we could go in there and make an impact very, very quickly.
Are there any metrics or some sort of measures that you kept based on the recent experience of the acquisitions? And would you be able to share with us the types of specialties that were brought in? For example, in Milford and Bridgeport.
Chris O'Connor again. I would say we have the ability to show what services and the growth of those services. I don't think we keep a detailed log of the physicians recruited and their duration geography. So we can give you part of the picture that certainly describes it, but maybe not some of the detail that is behind it.
I think that would be helpful. We can get that as a late file, a little description of that particular experience. If that's.
I think, well, that's going to be in the data that you requested earlier with Milford Hospital, with the Milford Hospital acquisition. So we can then use that to describe what services. So again, using a single example, I think would be helpful because we can go into more detail versus just giving you data.
Right, but if you can just tie it into this particular example.
Absolutely. I can do that.
If I could interject, Roy OHS. So the metrics that we were hoping to capture here is the recruitment advantages. So I know you were saying the brand, anything else that might be tracking the actual advantages, just so we have some evidence of it. I think beyond successfully recruiting a physician to a location, is there anything about the number that you had to recruit or something to show that?
Well, I think the backbone of the two employment models that we have to offer. So we have Northeast Medical Group that you've heard about, and obviously will be under a separate CON that has over 750 providers in that group. So there's substance there, but even more importantly, we have the faculty that we've talked about all morning with Yale Medicine. That supports the academic structure, and there's, I think, over 2,000. I'm looking for a nod. Yes, okay, 2,000 physicians in that group, clinical physicians in that group. So they're coming in. We have breadth and depth to offer, and certainly those are the largest groups when you combine them in the state. Please.
So just to clarify, into the request, I think what we're hoping to do is that what you've asked for is metrics if we have them on additional recruitment. And we can build that into the Milford modeling. So we'll be using the Milford example and trying to build out that information for you. To the extent there are specifics on actual recruitment, we'll do that. If not, we will work on the kind of subspecialty growth that Chris mentioned.
I think that would be awesome.
Thank you.
And to Roy Wong again, so to Mr. O'Connor's point that you just made about the faculty, the school of medicine, that narrative that you just shared, if there are any metrics and numbers like the number of faculty, that would be the additional part on the specific recruitment and retention. And I think partially that will be captured in the services and the positions that are added, partially will highlight the actual recruitment strengths.
Sure. We can do that.
Yeah, no, thank you, Tom Balsack. I was just gonna build on to your point. What we will be able to produce for you is we can, at each individual medical staff, each individual hospital has its own credentialed medical staff. What we can show you is the growth in Yale faculty at each institution. There have been some medical staff, some faculty at some of these medical staffs in the past, but after integration, what you will see is a very rapid growth in the Yale medicine faculty at each one of those campuses. We can take one as an example.
And I think that'd be great. I think we can use the same late file, but just make sure both the services as well as the physician providers.
We'll have to, I can give you department and section so you can perhaps see the crosswalk.
Let's just break.
Okay.
So let's take 5 minutes. We'll come back at 12:13. Actually, let's just take 12:15. Around number. And again, a reminder, please try to be quiet out there. If you need to have conversations, have them here or in the conference room.
Not really. 11. Electronics. 21st.
Recording again. Before we continue with questions, I did want to acknowledge that we had to eject someone from the Zoom hearing room because they were making inappropriate noises. And they also, I guess, had an inappropriate name as well. So again, please maintain decorum to the greatest extent possible. And certainly none of that will be tolerated. So with that, we will move back into questioning. And again, it's my hope to get through until 1 o'clock. I think that'll get through most of the questions that we have. Well, most of the OHS questions, I do have some of my own questions as well. But with that, I will turn it back over to Steve, I believe.
Yes.
Okay.
All right, Steve Lazarus, just have a couple more questions. Dr. Belichick, you had identified the deployment of Epic as one of the key methods to extend the clinical excellence to the hospital. Can you describe the estimated 12 to 18 months long implementation? I know you referred to it a little bit, and talking about the necessary changes to the IT infrastructure, resources, training for prospect hospitals, clinical staff, associate medical foundation, those things.
Right, thank you. I wish I could. I don't know that detail, but I do have a colleague, and I'll phone a friend, Lisa Stump, who is our CIO, and I'm sure give you that in very exquisite detail.
Hi, Lisa Stump. When we undertake an implementation of the Epic platform, it includes not just building the software and systems, but we start first with a very good assessment of the current workflows and clinical services and programs, et cetera. We then need to, in addition to building the system, so our team will configure and do all of the coding in the software itself. We're working very closely with the clinicians and the operational staff around the change management and the training that supports that conversion.
The consistent care signature that was been mentioned, is that part of this process?
Absolutely.
What's been the timeline to reach that level? Or maybe perhaps on the past experience with Milford and L&M you can talk about it, and what would be expected of these prospect assets.
Yeah, so let me take us up a few thousand feet maybe and go back to a description of the electronic medical record. And we tend to focus on it in those terms. And I would say that is really one aspect of what is really the platform through which we do our business, right? And so within the platform, it are all of the clinical content related to order sets, related to the care pathways that my colleague, Dr. Balsazak mentioned. And so when we bring a site live, when we convert the operation to using Epic, all of that clinical content is there. All of the clinical decision support rules that say, when a patient of this age and this weight is prescribed this medication, we flash an alert to a physician that says you might want to consider adjusting your dose. Or those care pathways that say, given the patient's clinical condition, their current laboratory values, you might want to consider these other tests that would add to your ability to advance the diagnosis of the care. And so I don't mean it to sound trite in any way, but literally the moment we turn the system on, all of that clinical content is brought forward. Tom's example around COVID absolutely exemplified that. And so literally hour by hour and day by day, as our clinicians were evaluating the evidence about how to best care for patients presenting with COVID, with the few keystrokes that it took to update that pathway, it was immediately propagated to all of our sites of care across the entire health system. That's the power of that platform. That's much more than just clinically documenting and placing orders that I think sometimes come to mind when we reference the electronic medical record.
And that timeline is still 12 weeks.
So we are hoping and planning to bring live the hospitals within 9 months of the acquisition. And the medical groups, I know that's a little bit outside of the scope of this hearing per se, but the medical groups will be brought live within 4 months. So we do view this as a key part of that integration and transition. And so we look to expedite it as best as we can.
And when we talk about the medical groups, you're talking in the outpatient setting?
Correct.
Is that the same system? Or is that like a?
It is.
Like,
No, so Epic is a fully integrated platform. It's got modules with different features and functions that are appropriate for a given site of care or level of care. So there is an ambulatory set of tools that are used in the physician offices. As an example, there's a module that supports the operating room and the anesthesia care, which is very different than other aspects, but it is all fully integrated. All of the data, as we talked about, the power of access to information about a patient, all then is consolidated around that individual patient from cradle to grave across that longitudinal health record.
thank you. Does Yale New Haven Health System track quality of care measures? For example, patient experience measures, 30-day readmission rates, 30-day mortality rates, at any of the previous hospitals that's it's required.
Yes, or required.
So can you please describe in general some of the changes at the previously acquired hospitals related to quality, specifically based on those measures?
Those are some of those measures. Some of those measures are operational measures, efficiency measures. Some of the measures are safety measures, and some of the measures are quality measures. There are literally tens of thousands of quality measures that are available for us to track. Some of the ones that you mentioned are mandated by the Center for Medicare Services, and we do track those and submit them on a regular basis. We do have an enterprise-wide chief quality officer who's really been instrumental in driving the clinical care pathways that myself and others have described, build them into our Epic medical record as Lisa Stump described. So it is because of those clinical care pathways that we've been able to see reductions in, for example, mortality, one of the most important clinical quality measures in virtually all of our clinical care services. We have a single enterprise-wide chief infection prevention and epidemiologist who runs all of our programs across our entire health system, Dr. Rick Martinello. He creates the standards for how we do infection prevention in all of our clinical care areas, whether they be ORs, procedural areas, or even in our racial units, the inpatient service. So I would generally say that we have seen improvements in quality, safety, efficiency in all of our institutions as we've integrated them and brought them in. But we've also been able to standardize care, and standardization in and of itself has its own benefits.
And that was my next question. So these measures are standard measures that you use. Would we be able to add that as part of that other late file that you're submitting as an example to provide some of those quality measures?
Yes.
Pre and post, so we can see some of the improvements. Maybe you can even explain the trending of that as well.
Yeah, I'm not so sure what we have is in the previous discussion, what we have available. This is Chris O'Connor, by the way. what we have available to us prior to the acquisition, we certainly can do post acquisition.
Yeah, well, like a baseline.
So we can use that first month as a
Yeah.
first quarter as a baseline.
That'd be perfect. With that, I'm gonna turn it over to my colleague Roy. Next few questions.
Sounds good, thanks, Steve. Roy Wong, OHS. So next series of questions are about improving cost effectiveness of healthcare in the region or preventing adverse effects of healthcare affordability to the consumer. My first question pertains to Mr. O'Connor's testimony on page 1486. We need to describe some of the commercial prices for L&M. So would you please describe the circumstances and strategies that allowed for a decrease in Lawrence Memorial's inpatient commercial prices 5 years post-acquisition and an increase in outpatient prices that were less than half of the state's proposed cap over that same period?
So I'm gonna ask to swear in our payer relations expert, Ms. Williams, if we
Okay.
could help us answer this question. Hold on, she's in the overflow room.
Oh, sure, thank you.
Kelby, you wanna begin? Or- all right. Thank you for doing this.
Sure.
Would you mind repeating the question?
Yes, sir.
Before we do that? Oh, yeah, you have to swear. Sorry.
First, can I have your name and your title?
Sure, Jeremias Williams, Senior Vice President, Payer Strategy and Innovation for Yale New Haven Health System.
And can you spell your name for the court reporter, please?
Sure, DEREM as in Mary, IUS as in Sam. Last name Williams, WILLIAMS.
Thank you.
You're welcome.
And now I have to swear you in. Can you please raise your right hand? Thank you. Do you solemnly swear or solemnly and sincerely affirm, as the case may be, that the evidence you shall provide shall be the truth, the whole truth, and nothing but the truth, so help you God or upon penalty of perjury?
I do.
Thank you.
All right, so just to orient you to the part of the record that I'm referencing, it's on Bates page 1486 is the first hot paragraph where Mr. O'Connor describes the decrease to inpatient commercial prices and then the increase in outpatient prices that were less than half the state imposed cap over that same period. So my question is just to describe the circumstances and strategies that allowed for that to happen.
Sure, so in negotiations with payers, relative to our contracts, we take the time to evaluate what the pricing looks like as a baseline and identify opportunities to right price. Some of the pricing structures in the L&M agreement at the time were different in terms of methodologies in place versus some of our other hospitals. And the payers identified some of that distinct discrepancy, if you will, as well. And so we just looked at opportunities to understand what the appropriate relative pricing would be for those services. So for example, if there was percent of charge pricing with some of the inpatient services, that might cause some of the prices as a baseline to be higher. And so as we attempted to establish fixed pricing over time, with that, we were able to modify some of the inpatient pricing while at the same time lifting some of the outpatient pricing. And obviously being conscious of the cap and the requirements relative to that.
Sure. And so are these strategies applicable to the hospitals across the board and individual hospitals? Could you describe kind of the approach to those rates for the hospital and the system?
Sure. So first of all, obviously, we've not had the opportunity to review those rates and won't until after the acquisition. As we've indicated in the documentation, we will assume the contracts as they are, pending the agreement and discussion with the payers. At that time, when we have access to that data, we would do a full evaluation of that pricing as well and pursue a common process in collaboration with the payers.
Sure. And as the map in the presentation showed, these hospitals are located in a somewhat different market than Yale's current market. How does that impact the negotiation of commercial rates?
It impacts it only to the extent that the geography that the hospitals sit in matter, right? And so as with the existing hospitals within Yale Haven Health System, the pricing schedules are not exactly the same. And so that type of difference is maintained relative to what is appropriate for a hospital and its unique geography.
This is Chris O'Connor, just to interject at one point, and I know we've been using, and appropriately so, our past examples as predictors for what may be affordable to us going forward. I do want to, in this case, be cautious because the financial environment that you see in Schedule A is very different today than it was when we undertook the Lawrence and Memorial transaction, and our ability to absorb that and manage through it is just different given the last 2 years of operating performance. So I just want to make clear that, you know, I'm not sure that they are going to be necessarily apples to apples at the end of the day.
Sure, absolutely. And I think some of the questions are geared towards lessons learned and strategies that did work, and then which of those might have applied. So since we have you here, I'm gonna, for my colleagues' benefit, I'm gonna skip to question 27, ask that now. Would you please detail Yale New Haven Health System's annual evaluation of charges process and how Prospect hospitals will be integrated into this process?
So we evaluate all of our charges on an annual basis. We have a team that takes the time to evaluate what our costs are relative to our charges, and we have a pretty disciplined process that's in place. It doesn't necessarily mean that charges will always go up. There are modifications that may happen up or down depending on what the circumstances are. But it is a disciplined process that our revenue team goes through on a daily basis, and we would expect the Prospect hospitals evaluation to be similar.
Okay. Continuing, just going back to the other questions. Has Yale New Haven Health Systems observed any diminishing returns of cost savings from the efficiencies of adding additional hospitals and affiliates dating back to its first acquisition of Bridgeport Hospital in 1996? This kind of speaks a little bit to the economies of scale. Just wondering if there's been any diminishing in the savings as the system has grown larger.
I think it depends on where, this is Gail Kosler. I think it depends on where those hospitals are coming from and what their particular systems look like today and the processes that they have today. So I think that, you know, for example, that, you know, a hospital is a standalone hospital that's doing all of the processes on its own. That might look different than one that was connected to another hospital that was potentially sharing services. So I think it's a matter of once we can get in and understand that aspect of the integration, that's where you would see whether there were you know, less returns or that's what we see in the past.
Okay, Chris O'Connor again, just for, again, using our past experiences, each one of our previous experience has been exactly as Gail was just describing, an independent hospital doing all of those services locally. So this will be the first acquisition of a system hospital. Obviously, Prospect nationally has that infrastructure. So it's a new example for us that we're going to have to evaluate, and therefore we have been more conservative in the expectation around synergies as a result of that.
Okay. That does answer my question of if there were any preliminary kind of expectations. So thank you for that. Does Yale New Haven Hospital System plan to acquire additional systems within the next 5 years in Connecticut or neighboring states?
This is Chris O'Connor. You know, there's nothing right now in any discussion that I would say that there's any disclosure or any opportunity that I would say is moved into a formal stage. You know, most of the hospitals in Connecticut have formed affiliations with systems. So, you know, we're not anticipating major acquisition growth in Connecticut now.
Okay. As you know, there are studies that show that consolidation and regionalization can lead to potential increases in prices and costs. Would it be possible to provide a year-over-year cost for the acquired hospitals? As an example of for example, the examples of decreases in costs or within a certain cap, just to provide additional evidence for our evaluation. that be something as a late
Well,
file?
so this is Chris O'Connor again, and you have that because we've been required for the last 3 acquisitions to report on our performance and. I think our history thus far would indicate that we have performed exceptionally well under those. Again, I want to be careful not to use those as examples of how we are going to have to go forward with this. You have both systems operating in operating deficits. So it's a different environment, but certainly you can look at our past performance and I would take issue, and I do take issue both publicly as well as within our team. With the assumption that acquisition leads to increased costs. That has not been our experience, and we don't believe it would be going forward.
Thank you. The next question is regarding the applicant's submission on base page 144, where it's stated that the applicants do not anticipate any immediate changes to their contracts as a result of this proposal. Under the asset purchase agreement, Yale New Haven Health Systems has agreed to assume existing commercial payer agreements subject to the payer's consent. The question is, would you please describe how future commercial contracts will be negotiated for Prospect, Connecticut?
Sure. So in collaboration with the payers, we will follow the same discipline process that we have historically. That we do analytics to understand what the baseline looks like, and we pay attention to trends that are important and that influence what the pricing needs to be in aggregate, but also by service. And so we'll follow the same process. Obviously, we've indicated, as you stated, that we would assume those contracts. And I also referenced that our existing contracts are not exactly the same across the system. So that same process will be followed, to your point, Chris, and it will be disciplined and objective. And again, in collaboration with the payers with an eye towards ensuring value for the community and the constituents that we serve.
Okay. Continuing a little bit on these commercial payer contracts, what might cause a payer or group of payers to not consent to Yale New Haven Hospital System's assumption of Prospect's payer contracts?
Sure. So the payers have their own unique administrative and programmatic requirements. And so it's going to depend on what their policies are, what their processes are, and what they're able to administer. And we will know that once we actually get into those conversations.
Switching a little bit back to the savings realized as described on base page 1486. There were realized savings of 46 million at Lawrence Memorial post affiliation. And it goes on to state that the financial benefits were passed on to the patients as well. And how much and through what financial mechanisms are the financial benefits and savings passed on to patients?
So you indicate the pricing decreases, and some of that is patient share of those costs. And so those would be passed on to the patient in the course of collection.
And so with that example of the 46 million and also the 638 million in cost savings at St. Rayfield's from 2012 to 2020, I believe, is that similar in terms of how the savings are passed on?
That would be the indication. Those
Okay.
would be patient portions of the bill.
Although Chris O'Connor, again, during that time, when we had significant synergies, the hospital provider tax was implemented. That was a major financial blow that impaired our ability to deliver those savings directly to patients.
Okay, so I guess, oh, sorry.
I was just gonna add, Gail Coslow, I was just gonna add also that synergies within a system enable a lower total cost of care, because there are, with access to patient tests and records, there's some duplicate services that are then not performed. So that is also an additional savings to both the payer and the patient.
Okay. Would it be possible to get an accounting of the cost savings as a late file, just to show kind of where the cost savings are?
Is this the same request that you had said before, the kind of the areas of the cost savings?
Well, so this is specifically to speaking to how the patients are benefiting, just to get, you know, you're saying that through L&M, there were 46 million, through St. Rachel's, there was 638 from 2012 to 2020, just breaking that down by year perhaps, and
think it'll be difficult because it assumes the mix of patients and the services are exactly the same.
Okay.
So you would, I mean, it would. Again, if everything were exactly the same, you could calculate that, but that's not the way it happens. It's not, they're not, it's not a manufacturing organization of patients and different needs, and I think it would be difficult to. But the colleagues have a different opinion on.
Well, and the other caveat to that, this is Chris O'Connor again, is that, our ability to deliver those savings has then helped supported the investments that I also spoke of. The infrastructure investments on the St. Raphael's campus, and now obviously building towards the neuroscience tower. That's going to be a world-class care center. Same is true in New London. We're put a power infrastructure and expanded their emergency department. So, it's not just delivering to, going back from a pricing standpoint, it's also our ability to invest in the infrastructure and clinical programs at each one of those locations as well. So that's where it gets a little bit complicated. It's never a one for one.
Sure. So instead of the accounting of these things, is there a way to maybe have a narrative of the methodology that you're describing as to how that's generated? Or
You could provide an example or two of
sure.
something.
Yeah,
Like
I think a narrative will be more feasible.
Perfect. Okay. That concludes my questions. I'll hand it back over to Steve to complete the OHS question. Just the three of us before hearing Officer Chuka added his questions.
All right, Steve Lazarus again. Can you? So on Bates page 168 of the application,
168.
168.
It's the original application. Pardon me.
Way back.
Yeah.
Not sure that it's necessary that you found it. If someone
Okay.
continues with
Yeah, if you want to start with the question, we'll figure out if we can answer that.
That page indicates that Manchester Memorial Hospital provides PET CT scan as one type of imaging services provided at the facility. There is, however, no further mention of the PET CT imaging equipment in the application nor in the acquisition of the equipment supplemental form. What is this Yale Systems the applicant plan for the PET CT scanner?
It's
And specifically, it's the General Electric Discovery IQ PET CT scanner.
Still.
it was a mobile. Do you want to speak to that?
So let me just confirm.
Yeah, can you repeat that question?
Sure.
I believe it's in.
So, there was a mention of the PET CT scans in there, so we're trying to figure out. If there was no mention of the PET CT scanner after that, there was no supplemental that was included as part of the imaging.
Right.
So can you tell us a little bit about the PET CT scanner and what's the plan for that scanner at this point?
Sure.
Who would know, Dean? What? Mark? Who would know?
Got it. We're on it. Yep, that's right. It's a contracted service. Sorry, Deborah Wyman, the contracted service, so it's a mobile unit that we don't own. That comes in, provides a service and leaves.
Okay, so moving forward, does Yale System plan to continue that service or take that over or no?
It's Chris O'Connor. Highly likely we're going to need PET CT at our hospital campuses. It's a standard of care.
So I'm just trying to say, would that not require acquisition of this? It's contracted, but you would take over that contract.
Not necessarily. I think we'd have to look at it. I don't know if we have due diligence that speaks to that or.
Yeah, Gail Costa, I was just gonna say that whatever costs associated with that lease would be replaced with costs associated with the acquisition and running of one. So those typically mirror, I mean, I haven't seen this one, but those typically mirror it. So that would have been, would be something that we would evaluate whether that lease continues or whether it's acquisition.
Do you know when the lease comes up on that piece of equipment?
I do not know that. No, I could get back to you. It's a per use type of arrangement, so we call them, they drive in, use the system, they leave.
Okay. I'm just gonna put a pin in that topic for now. We should discuss that with my colleague there. Can you please explain the low utilization volume reported on the Manchester Memorial Hospital's MRI? And for the 2 MRI scanners and the 2 CT scanners operated by Rockport General Hospital and the Evergreen Imaging Center LLC. And can you then provide an update for fiscal year 22? So I see the volumes have increased, looking at the utilizations of those.
Let's start with the first part of that question,
Yeah.
the low utilization volume.
Yeah, we can talk about that piece first.
So I'm sorry, can you repeat the question?
Sure.
for-
So can you explain the low utilization volume reported on the Manchester Memorial Hospital's MRI? And for the 2 MRI scanners and the 2 CT scanners operated by Rockville General Hospital and Evergreen Imaging Center LLC.
It's just for, is there any particular page that we can direct us to? Or this? I apologize, this is Kim. 170. Okay, 170 for those folks.
So you're inquiring on the low volume
Yeah,
for the utilization
current
of the
utilization.
imaging
Yeah.
equipment.
Yeah, what are they? So I'm reflecting. Yeah,
Yeah.
I would agree. So I'm referring to this, the Rowena, sorry. I'm referring to the report 450 under Rockville General Hospital MRI scans year over year. From 21 to 22, it actually increased by 172 scans, so I'm not understanding the question.
I think we were going off the figures that were submitted as part of the, whether we did not see the one, so between fiscal year 2021 and 2022, you're saying that the numbers increased.
Yes, that is what I'm saying. They increased both at Rockville General and at Manchester Memorial. There was 231 cases in Manchester and 172 in Rockville.
You are referring to the HRS report 450.
That is correct.
I would like to go and provide afterwards.
Okay. We'll put it in. We
Have
can
it-
put it in the report too.
Okay.
Yeah, and there may be a discrepancy between that and
Move its files.
the bait stamp
Okay.
reference.
So we'll
Yeah.
come back to that later on. We also want to review those. Thank you.
Great.
So that's all of the questions that the other OHS staff has for right now. We're going to break for lunch now. Steve, do you think? So let's come back at 1:50. And we will pick up where we left off. A reminder to the public, if you want to make a public comment, please sign up either in Zoom or at the sign up sheet out front here. And also, I don't know whether we'll be keeping the Zoom running, but if we do, yeah, we'll be keeping the Zoom running. Just make sure you turn the volume and the video off while you're not at the computer. Thank you very much for recording. Welcome back. This is the hearing for Yale New Haven Health Services Corporation and Prospect CT Inc. Docket number 22-32594. regarding the acquisition of a healthcare facility pursuant to 1998-638A2. We have a couple questions that remain, and a few other things that I'm going to have Steve go over. And then we're going to go into my questions. In terms of public comment, just a reminder to everybody who's attending via Zoom or anybody in this room or the other room who's a member of the public. If you do want to make a public comment and you haven't already registered, you can do so anytime before 3 o'clock. I think we're doing pretty well on time right now, so we'll reevaluate as we get closer to 3. But I think I feel pretty good about us being able to finish today and not have to go into tomorrow. So with that, I'm going to turn it over to Steve to just button up a few items.
Sure. Steve Lazarus. So when we left off, we were talking about the PET CT and MRI and the CT volume. So we were able to go back, check 450. So we're fine on that. And I think we could reconcile that ourselves. Talking specifically about the PET CT that we talked about, that was alluded to on page 168. So that's a service that Yale is planning to take over. Has continued that service. So we would probably need a supplemental form submitted as a late file for that one. So this way we can incorporate that as part of this particular agreement.
We don't, like, I think as we sit here today, we don't know the details 100% around that arrangement. We think it's not a hospital owned or leased CT or PET CT, and that it is in fact built and operated by another provider. So I think we just need some additional information.
Well, you just want to know that that service would continue.
Well, we need to understand, first of all, what the ownership structure is, and if Yale, as part of this acquisition, is going to continue that service, and how would that be structured? And if it is, it's best, in our opinion, it's best to sort of wrap it within this CON than to eventually have to come in for a separate one.
We agree.
So depending what we can find out, we can talk as part of the late files afterwards. We can decide whether you can submit us, if it needs a CON, then we suggest we submit a supplemental.
Yeah. Okay. Yeah, we'll get that information and we can talk with you about the right procedure for adding it.
Yep.
At the meeting.
So my last question, and this goes to more the community need, is if you can talk, discuss a little bit about the impact of Prospect CT's changing ownership from a for-profit to a nonprofit entity. If the transfer of ownership is approved, what impact would that have on the community itself?
Want me to take that? Chris O'Connor. So we anticipate that, as I said in my testimony, that it would not only would we continue to support current community activities, but we would and have historically enhanced community relationships after acquisition. So the community support, it's both in terms of our care that we're going to provide, as well as the community benefit that would be yielded from that care. So we're very confident that it would be enhanced.
Perfect. And what about what impact would it have on anything such as operating agreements, governance, management, taxes, whether state or local, bylaws for the hospital, and any other joint ventures that are involved in this acquisition?
Well, I mean, the first thing that in the conversion is that any profits are going to be reinvested into the entity itself. So that, I mean, that's inherent with all of us as not-for-profits. Governance, we are looking to manage from a regional perspective. So we've looked at local representation from those communities on a government structure. Yale New Haven maintains local fiduciary boards. So we have a system board that holds, the certain rights and responsibilities, for instance, approving budgets, capital spending, those types of determinations. But the local presence in governance is very much a core part of our organization's expectation.
And I think it was your testimony at the beginning this morning, you talked a little bit about the community benefits. Can you talk a little bit about what type of benefits can the local communities for Prospect Hospital expect the Yale sort of coming in?
Again, similar to what we have described with the clinical programming, until we get into the community and hear from them directly, I don't want to sit here and assume where they would best be aided and assisted or enhanced. We would want to have those conversations in the local communities to make those determinations. But again, you can look at our history and see that we have enhanced it in all of the communities that we've become a part of.
And just Steve, in the conversion legally, they'll be required to conduct community health needs assessments. So, which as for-profit is a requirement. So that, you know, in terms of polling the community and the services, that will be done, you know, via legal requirements of community health needs assessments being conducted.
All right, thank you. That wraps it. Well said, thank you.
Right. So I have some questions also. Some are going to be directed towards Prospect, others are going to be directed towards Yale. I first wanted to start with the topic of consolidating the Manchester Memorial license with the Rockville General license. Mr. O'Connor, as you acknowledged earlier, this is unlike other acquisitions Yale has done in the past, because Prospect is not an independent hospital. So although it has consolidated licenses in the past under similar CON applications, I'm not entirely convinced that that's going to be an option here, just because of the way the CON application has been filed. So just to give you a little background, in docket number 32405, the application also involves the increase in licensed bed capacity, and in this particular instance, we don't have that. So just to the attorneys, I'm going to ask that a brief or some sort of memorandum be submitted on that particular issue.
Can we just get some clarity on that?
Sure.
In terms of the bed capacity, we just want to make sure there's no miscommunication. That's an OPA category in terms of increased licensed bed. In the docket number for the licensure consolidation, there wasn't a request to increase beds. It's an automatic increase when you consolidate the two campuses, the two facilities under one license, but it's maintaining the existing beds in the communities that are already available and under the existing license.
I understand that.
All right.
I just want to make sure that if this is eventually approved, that we're on firm legal grounds to actually agree to consolidate the licenses. So because that's what Yale is operating under the assumption of right now, that they're going to be able to do that by us approving this.
Right.
And that's just my concern, and I think it needs to be addressed before this can actually be approved.
Okay,
I'd be happy to submit a memorandum on that and highlighting areas where at least, you know, the consolidation feature has been made clear in the application.
well, Ian, in terms of the other dockets that you took administrative notice of, I mean, Yale has a history of in an acquisition, combining it under an existing license, obviously Milford with Bridgeport, St. Raphael's with Yale, and it's all happened at the time of acquisition. So this transaction, you know, doesn't differ in that respect. So in terms of legal precedent, I think you do have that with, although OHS doesn't rely on precedent, you do have the existing dockets that you took administrative notice of to allow legally, to have it be permissible, so.
Except that this is different, as Mr. O'Connor acknowledged. This isn't like the other Yale acquisition.
Well, in what way?
Right.
Why not? Why isn't it like the others?
Because it's acquiring Prospect ECHN and it's two hospitals, and it's saying it's going to consolidate those two hospitals rather than sort of bringing the hospitals directly under Yale.
Well, a lot of that has to do with geography, right? I mean, part of it is geography, and fortunately, in the other acquisitions, the mileage and proximity, afforded that. I mean, and to get some of these synergies and efficiencies and to implement the 4-phase plan, I mean, it's imperative that they have the ability to consolidate the licenses.
Can I just
That's
ask one?
my concern, like. I'm not saying it's not in the best interest of, if this is approved, I'm not saying it's not in the best interest of Yale to consolidate the licenses
And the community.
and the community. I'm just saying, I want to make sure we're on good footing to do that in this particular case, since it is different. So, and I want to make sure that Yale is comfortable moving forward with their project as well. Assuming that we're to go forward.
We will absolutely submit the memo. I just wanted to add that this is an asset purchase agreement. So this isn't a merger of, one hospital into another hospital, it's an asset purchase. And so we have described this structure by which we would purchase it. It is technically a new hospital. At that point, the bed capacity is not being increased as Michelle noted, the bed capacity is the same, it's just being consolidated. But this is an asset purchase. So I just wanted to make that clear, and that, some of those other, I believe the Milford was as well, right? So it's simply a way of taking in the assets. We're just describing the mechanism by which we plan to do that here. So I think it's actually not different from those other transactions in that, with respect to this licensure issue, I think it's the same.
Okay. Thank you. So I'll just have you submit a memorandum at the same time as you submit a late file.
Perfect. Thank you.
It doesn't need to be terribly long, and it just needs to, I need to feel comfortable with that. That's my option.
Absolutely.
So keeping with consolidation, I did want to ask some questions specific to this application and what we could expect if you were to consolidate. So these questions are directed first towards Prospect and its witnesses. Can you explain what the current process looks like for transferring a patient from Rockville General to Manchester Memorial and vice versa? Are there currently any delays in transfer that would be eliminated by approval of this proposal?
Hi, Deborah Weymouth, to address that question. Currently, we are not on Epic as established earlier. We are on, for our emergency services, a software called All Scripts. So it does require, when we're transferring a patient from the emergency room over to Manchester, a transition from All Scripts to Meditech, which is our in-hospital provider, assuming they're going in as an inpatient. So there are technological issues there in terms of changing medical records that need to be modified and so forth. We do have a streamlined process that we've established, orders that are standing orders written and to allow the facilitation of a transfer as quickly as we can. But we would anticipate that when this transaction is completed, that would be even faster, because as established earlier, it would all be on Epic instead of jumping back and forth between two separate systems. And then also, the anticipation would be, just because of that, communication would be enhanced. Now we make phone calls to receiving physicians. They obviously have to go through a Q&A process. Again, much of that would be expedited through the update to Epic. So we do have a process now. We move through it as quickly as we can. We are dependent on the local ambulance service to help support us in transferring the patient. And that is a variable that we don't directly control, but we work with them on a regular basis and they've been very supportive.
So in various filings here, I've noticed that Prospect is still on Meditech as their primary EHR.
Correct.
In that the consolidation docket, it was testified to that you're in the process of transitioning over to Cerner, which is what Waterbury Hospital was on. So it's been quite a bit of time since then. Is there a concern that transitioning over to Epic would pose a problem here? Like, I'm just not sure why you haven't transitioned over to Cerner at this point.
So we didn't transition over to Cerner only because this particular opportunity appeared. And we knew that Epic was the ultimate goal. I mean, I'm not saying Cerner's not a bad product. I don't know if they're on the line. But Epic is obviously the gold standard that we would like to go to. So given that, the other piece to be aware of is a transition with technology. You don't want to be doing them once a year. It's a big event. You need to train the people and, buy the appropriate equipment and so forth. So we wanted to have that happen at the time of this transaction and only do it once instead of having to change and then change again.
Okay, that makes sense. So in a number of places throughout the application, Yale provided data for ECHN as a whole rather than by separating out Rockville General or Manchester Memorial. So I think for our purposes, like that is helpful, but we'd still like to have the two separated out as well. For example, page 81 of the application, table 9, page 83 of the application. That's regarding gender, race, ethnicity, and age. And pages 128 to 129 of the application, that's tables C1 and D1. So it's basically just asking you to separate out the utilization and the rel information, so that it's not all grouped together as ECHN. Would that be something you can do?
Potentially, that's a problem.
Okay.
The version of Meditech we're on is very old and does not have that in some cases to that level of detail. We will certainly make an effort, but I can't guarantee that I can do that in all instances that you just listed.
Okay.
I do know that the COM team had looked at that, and I mean, the intent was to, because that was asked, but I think the technology didn't have the ability, capacity to get down to that level.
Okay. Well, we'll make it a late file, and if you can't provide that level of details, that's fine. You can just say it as much.
You will. Thank you.
Would you mind just reiterating the specific table number? I just want to make sure we have. a good
These were examples. There may be others, but so page 81 of the application, it's table 9. Page 83 of the application. There was some information there provided for gender, race, ethnicity, and age. And then pages 128 to 129 of the application. That's tables C1 and D1. That's all of the questions I have for Prospect on consolidation. I do have some for Yale as well. And I'm sorry to belabor this, but I was hoping someone could speak to the specific benefits that consolidation would provide in this particular case.
You want to take that?
There are 3 broad categories: cost, quality, and access. Those are the 3 benefits of consolidation. And the cost one is obvious. if you're operating two similar services 9 miles apart, consolidating into a single location, it makes an incredible difference in the ability to field a team, high quality team, and drive down per unit cost. On the quality side, again, there's innumerate pieces of literature to show that volumes are associated with quality. Low volume programs simply are just not safe, and they're not of high quality. And the third is around access, which is if you're providing OR services, for example, at Rockville, on the inpatient side, only a half a day per week, and you've got your schedules of anesthesiologists, surgical techs, circulators, etc., then I don't know how you provide access to patients that need surgery on the other 6.5 days during the week. Programs we tend to focus, or clinical programs, we tend to focus a lot on physicians. But we as physicians know that we are kind of the least important group of individuals when you're developing a clinical program. If you're developing clinical programs like what we develop within our service lines, they are extremely highly dependent upon nurses, techs, physical therapists, occupational therapists, psychologists, nutritionists, etc. You simply can't put a program that you want to put around inflammatory bowel disease or heart failure without that wraparound set of services. And you're not going to be able to provide access to those patients of what cutting edge care is in a program that just can't have the number of patients to sustain it and sustain those wraparound services.
Thank you.
Can I just add one very minor point on that, the benefit, which I think has been mentioned in the papers, but maybe not specifically here, which is that there has to actually be, if there's an inpatient that is transferred, there is literally has to be a change in discharge and readmission. So that's like pure consolidation without considering anything else.
And I recall that from the other,
Yes.
the other doc as well. And that actually ties into this next question, just for my edification on Epic. To your knowledge, are you able to open 2 different clinical records at the same time in Epic? Or so, for example, if one doctor at Rockville General had opened one medical record, but he wanted to see what was happening at Manchester Memorial, would they be able to do that without licensure consolidation?
I'm gonna ask Lisa Stump to.
Okay.
Lisa, CIO, the record sits around the patient. So it's not a separate record at one hospital or another. It's the patient's record regardless of where they are seen. So if Lisa Stump as a patient is being seen today at Manchester Memorial and tomorrow at Bridgeport Hospital, it is one record that is Lisa Stump's, and all of my visits are there regardless of where I have been seen.
Multiple people can view that at a single time, correct?
Correct.
Might be useful to give a clinical example. A clinical example is, I think, Lisa, without exception, perhaps there are small numbers of exception, every OB practice from Yale Health is on Epic. Why OB is a particular important specialty is babies come all hours of the day and night. There are certain special tests that moms to be undergo prior to delivering around antibody testing, certain risk of certain infections, beta strep and so forth, that it's really very, very important when the patient presents to the emergency department or admission department for admission upstairs, that they have immediate access to that data. That data is always collected in the prenatal visits. Those prenatal visits are almost entirely done in the private physician's office or the community physicians or whomever. And it's very extremely useful. It improves duplication of services. And if that one physician who's been seeing that patient isn't on, a separate physician can immediately look in that record, which, as Lisa points out, is exactly the same record. They're not mirror images, they are not replications, it is the same record. And they can see immediately that the antibody tests were done, the beta strep was done, all the prenatal things were checked, so that the physician who has to make very rapid decisions for that patient doesn't need to send additional blood tests, doesn't need to do additional evaluations, doesn't even need to make a phone call. Because as soon as they bring that up, he or she has that information immediately at their fingertips. That's one small example, but given the volume of births that we have across our system and are about to add, it's a critically important one because those decisions really need to be made in the moment.
Thank you. For this next question, I would like you to turn to page 1041. That's in the response to the completeness letter number 1.
Oh, that's right. Let the record reflect.
What the heck?
If there's a particular area that you'd like them to focus to?
There's just a quote that I wanted to receive some elaboration on. It starts, Yale, YNHHS's preliminary assessments focused on your regional approach.
Yep.
We're getting there.
I can read it.
You got it.
Okay. So it just says. YNHHS has conducted further review and determined that certain services at the ECHN hospitals will be provided more safely and cost effectively and in a manner that better serves community needs. They're consolidated. So my question was just, what happened between when you filed the application and responded to the completeness letter? Like, what was that further review that was conducted by Yale?
Oh, that sounds.
I mean, I don't recall exactly the specifics between the two timeframes, but I mean, I will tell you that we looked at volumes. We looked at the average daily census of Rockville being less than 5, approximately 3. We looked at the surgical volumes at Rockville. We got a little more information on what kinds of surgeries that were being done there. And they were, there are adequate operating rooms for many kinds of surgeries at Rockville. And as I mentioned before, it's not necessarily the operating rooms or even the availability of just the surgeon. It's the entire team and anesthesiology, scrub nurse, circulators, etc. And we believe that having access to those surgeries and having only an average daily census of 3 just isn't an economy of scale that's large enough to ensure high quality care.
Montana gave us some question.
To your point about med-surg not making sense to continue at Rockville General, probably. I'm not gonna hold you to that because I understand that you do need to conduct your evaluation, but you were talking also about sort of expanding inpatient heart and vascular oncology, neonatology and urology services. So I was wondering how you were able, like, what information were you looking at when you came to that conclusion that those would probably be areas that could be enhanced or expounded upon?
So I don't have the specific answer. This is Chris O'Connor. I don't have the specific answer for the detail, but I can tell you the process that we undergo and will undergo again once we have access to complete information. And that's our Office of Strategic Management goes through a full, volume and demand analysis within the communities. And then we look at what services match up to our ability to deploy those types of physicians and care teams in those geographies, and then make determinations. it may not be new demand, it may be demand that's leaving those communities and going to other facilities that we believe would be better served in their local communities if they had enhanced services. So I mean, it's not a single data element. It's a, you know, obviously multivariable process that takes place. And Dr. Ahuja, who is our chair of surgery at the Yale School of Medicine, and if you could swear her in, I think she has some information that would enhance my answer, which I deeply appreciate.
And I didn't swear you in,
No,
right?
not yet.
Okay.
So
Uh, Can you state your name for the record and your title?
So Nida Ahuja, first name Nita, last name Ahuja, AHUJA. Chief of Surgery at Yale New Haven and Chair of Surgery at Yale School of Medicine.
Thank you. Please raise your right hand. Do you solemnly swear or solemnly and sincerely affirm, as the case may be, that the evidence you shall give shall be the truth, the whole truth, and nothing but the truth, so help you God, or upon penalty of perjury?
I do.
Thank you.
So I just wanted to expound on some of the comments that Dr. Baltasek and Mr. O'Connor made around the consolidation of services between Rockville and Manchester and what has changed. In terms of evaluating the census at Manchester, as Dr. Baltasek mentioned, it's a very low volume census. And in terms of providing safe care at Rockville, safe care of these services, I think it's not only providing a physician, but the wraparound services. So just imagine if you need a acute operation in the middle of the night, you need anesthesiologists, you need the nurses, the scrub techs, all of those services to be available in around the clock. And to do these in two places would be unsafe. You really just need all of those, not only the physician, but those services available 24/7. And the distance between the two hospitals is very small. It's less than 10 miles. I think the example of this is what we do very well currently with our shoreline emergency, where patients get access to care in the emergency department 24/7 in the middle of the night. And depending on, and then if they need acute care services, whether it's a heart attack or it's surgery for a gallbladder or a hernia that's incarcerated or some acute abdominal emergencies, they're able to come in and get that service safely. And I think to us, as we look into all those factors, this makes a lot of sense that we need to provide the emergency room availability for those patients in this community. I think the other part is medicine has gotten more complicated with time, and to provide those services and raise the level of care in these communities, this is where we're seeing that you can't maintain this with 3 patients a day. That's not essentially safe. So I hope that helps in understanding some of our decisions.
This is Tom Belzak. I'm just gonna pick up on something else. I'm not sure we fully answered for you, which is, I think you asked the question of what was the difference between when we initially filed the CON and when we gave you our preliminary plans. Is that what you were asking?
Yeah, between when you filed the application and when you responded to the completeness letter responses. I'm not sure.
So there's a couple of things. We were able to get more information. We were able to do a facilities tour. I believe during that period of time, and I asked my prospect colleagues to confirm this, is that for a period of time during COVID, the inpatient service at Rockville was closed. And when we, I think, filed the first CON, it was either just opening or hadn't yet opened, and we've not seen, and as the time has progressed, even though it's now open, we've not seen a rebound in the volume. And that ties into what Dr. Ahuja just said, which is we would be very loath to operate a service of which is small as it currently is, just certainly just isn't safe. So the combination of talking to providers, talking to looking at the facilities, looking at the data for when they've reopened after COVID, has led us to that additional conclusion that was reflected in those questions.
This is Kim Reinhardt. I just wanted to mention that when there's a reference to shoreline, they're referring to the Guilford site, which has a standalone ED, but it's part of, so I know you had asked for us to clarify and kind of hands that move and more information.
I appreciate that. Thank you. Is next. I just have 2 quick questions about services. well, sort of about services. You reference medical legal partnerships with organizations and other entities in the area. I was curious if Yale had identified any organizations that I might partner up with in any of the locations of these hospitals for purposes of providing medical legal partnerships.
Sure, I'll take that one.
Please.
Bill Hasseltine. And I'm the head of the legal department at Yale New Haven Health. We started our first medical legal partnership probably about 14 years ago, and we have since expanded it. It's been very successful. My colleague here, Ann Diamond, has requested that we extend what we've done at Bridgeport, and we're working on that. We partner with the Yale Law School and getting law students to come in and provide legal services along with outside attorneys. And the concept is embedding lawyers in the clinical setting, because sometimes the impediment to healthcare is actually a legal issue. So when the lawyer is embedded in the clinic, the lawyer can sometimes resolve that issue in tandem with the team providing medical care. We have started to reach out to community organizations in the Prospect geography. We've had folks talking to the federally qualified health centers to see what we can do in partnership with those organizations. We haven't gotten too deep into that because we're letting this process play out. But I'm very enthused about the opportunity that we see here. So we will go all guns ablaze on setting up more medical legal partnerships in this geography.
Thank you. There's also a reference to transition services agreements somewhere in the application. That's a term I had never heard of before, and I was just wondering if some clarity could be brought to that term.
Sure. Chris O'Connor. Those are services that we would typically in a case like this ask for the purchasee to continue to provide services potentially beyond the date of close to ensure that they have continuity.
Okay. Are any of those contemplated here?
We're exploring a number of options, and it would depend upon closing and notice, and there's a whole sort of number of factors that would determine whether those would be necessary or not.
Okay.
But in this case, again, you have a national firm doing centralized functions outside of the local hospital that we want to ensure that things like billing and coding and things that we are going to need to continue as of day one, that we may not have had the opportunity to make the transition abruptly. So it again, it will depend. And I'm not saying those are the right services. I'm just using those as examples.
Tom Balsazak, and I'll add to what Chris just said. Lisa could probably help us here, but a perfect example is we talked about going on to Epic. We cannot go on to Epic the day we close the transaction. We must continue their electronic medical record. It's absolutely key to clinical operations. So we would need to execute an agreement to pay Prospect to continue to operate Cerner under the current license that they have for a period of time until we're able to transition not just Cerner, but all the electronic records. You simply can't operate an organization with no electronic medical record. We would need a bridge time to get on to Epic.
Yeah, Tom, this is Lisa Stump. Tom said that exactly right. So part of the transition services agreement will be just that, to continue to rely on Prospect to give us access to the Cerner electronic medical record, as well as the Meditech systems in use, as well as the teams, the IT support teams that work on those systems. We don't have that expertise internal to Yale New Haven Health at this time. And so for that 9 months or so until we transition everyone to Epic, we will be reliant on Prospect to provide us those services.
This is Michelle Volpe. I mean, from a legal perspective, that's a fairly common occurrence in this type of transaction. Position to have a transition services.
On page 68 of the application, you said Yale plans to fund the acquisition entirely out of its cash reserves. And then you said there's no funding or financing anticipated, but Yale may consider obtaining financing if there were a few different ifs, one of which was the timing of closing is significantly different than planned. and you projected, or that you hoped the closing would occur in June of 2023. That's obviously probably like pretty ambitious and not going to happen. So I was just wondering, what would significantly different than planned be from June 2023? And with the goal just being like, at what point would you have to consider financing under that condition?
Gail Kozlov, CFO. We anticipate financing this through cash as was indicated. Nothing would change that other than, other factors where we might want to consider if the bond market were such that it was advantageous to us to do that. But the plan is to fund it with our cash, our reserves.
We have a few more questions. If you can turn to pages 146 and 147 of the application. Specifically looking at subsection O, little o. And my question is just, these prompts were responded to from the perspective of prospect only. But the statute and the question refer to Yale as well. So I just wanted to make sure that we had Yale providing responses to that as well. And I wanted to make sure that was possible before we asked for it as a late file.
Yeah.
There are no financial gains.
Okay.
We're not with Roxbury, Texas.
I just want to ensure that that's part of the record. And that's clear.
Would you still like that in the late file or the answer
Oh,
on the record?
your answer is good enough. Thank you.
That was Chris O'Connor about it.
Thank you. Page 178 of the application, you say Yale will seek consent of other joint venture participants. To Yale assuming prospect of interest. Has that happened yet? Have there been any communications with the joint venture participants?
Yeah, Bill, I'll tell you, that process has started. Each joint venture, I think, has their own consent rights. So I know that we've initiated that. ECHN has initiated that in at least one of the joint ventures.
But you haven't gotten full consent from any of the joint ventures yet?
I think technically it's probably, Michelle, it's probably ECHN that gets the consent.
Yeah, and we will, like Bill explained, a lot of the operating agreements are differ in terms of, what's required in getting consensus. Some of them, pursuant to the governing documents, we don't anticipate any problems.
Keeping in line with the joint ventures, page 749 of the application. The joint ventures list prospect ownership percentages, but they don't list any of the other percentage ownership. I was hoping to learn more about those joint ventures and what the other percentage of ownership interests are, where those lie.
The ones that are a part of this transaction in this
Yeah.
CON. We have others that we filed determinations for.
So again, that's page 749, it's exhibit 11A.
Officer Chuka, I think that the information you're looking for is on page 179 of the application, actually for the JVs that are part of this application. There is a list of the other owners. Michelle, I think that was what they were asking.
Yeah, I don't know
Okay,
if you have a specific question on that.
no, I just wanted to ensure that we have that somewhere, and I didn't see it in that,
It's in the org chart.
okay.
But yeah, page number 179, for the three JVs that are relevant have more detailed information on ownership, as well as governance.
Thank you. And my last question concerns the RFP process, the other proposals and the FTC filings. I'm not going to ask specific questions about them. In a couple of your responses, you said, you know, communicate with the Office of Attorney General to get more information about this. I did communicate with the Office of the Attorney General, and they said that the applicants hadn't firmly waived their right to confidentiality, so the Office of the Attorney General cannot speak with us about that. So we need to find some way for us to be able to communicate with the OAG. Whether that's you waiving your right to confidentiality or you providing us with the requested information like directly, but like under seal or something along those lines.
Yeah, I mean, in terms of the specific inquiry, and we can also invoke executive session with you, but is there specific questions on that? I mean, that process that you're referring to, obviously, the federal government through the FTC had a significant review and oversight and, allowed permitted the transaction to move forward. The Office of the Attorney General as well has looked at the proposed transaction and gotten comfortable with the parties and proceeding in the manner that it's been described in the certificate of need. So I guess, and for those who aren't aware, and I know you're aware, the Office of Health Strategy has a separate CMIR process for the cost market, impact report, who is also privy to confidential non-public information. So there have been a lot of regulatory bodies reviewing those specific and definitive issues. And I guess I would ask, is there something in particular that you feel is necessary for purposes of OHS in the CON analysis that we can help with, and maybe perhaps have a executive session sidebar, or so that we could advance this issue?
So in my mind, the issue is, I don't know what is in those documents, so how am I going to ask specific questions about them? Maybe some of it would be relevant to the CON. I don't know.
Well, I mean, I guess we would argue it really isn't relevant, because the statutory factors that you review, the 12 statutory factors for purposes of determining whether, a CON is permissible, that information doesn't necessarily get invoked in terms of and based on Mr. O'Connor's testimony earlier, when he had the chart up, I mean, just from a layman's perspective on the antitrust issues, I mean, these aren't truly overlapping markets from where Yale currently has facilities. So I guess for purposes of your analysis, we recognize you're not aware of what's in the reports, but what is it that you feel you need based on the statutory factors? Especially because now, this OHS does have the CMIR process as well. So its agency does have an opportunity to weigh in from that perspective. I know you have a wall internally on that, but again, is there something specific?
This is Roy Wong, OHS. Is it possible for us to take a quick break to discuss that question?
Sure.
That Attorney Volpe just posed regarding the various criteria that CON oversees?
Sure.
Okay.
And
I think we could also collaborate on a way to provide, limited information or to have a limited waiver, whatever, we can work out that legally it functions.
Yeah, I'll weigh in. So again, Bill Azzeltine, Yale New Haven Health. So the concern, we filed the Hart-Scott pre-merger notification to the Federal Trade Commission, which is copied to the Attorney General. We filed that on May 12th of last year, I believe. We met previously with both the FTC and the Attorney General, I think in February of last year, to preview what we would be filing. They did give their 30-day clearance, which is a little unusual these days. Usually the FTC automatically takes an additional 30 days to review transactions like this. They didn't. They had enough data to give that 30-day clearance. That is expressly filed under a federal statute that says that that is non-public information. We are not willing to waive that because it contains competitively sensitive information that if it were to become public would materially harm us. Our competitors would have a lot of detail about our organization's strategies. On the other hand, there's probably a way to negotiate something if we understood your concerns a little more clearly that we could work with you on. And again, we've stayed in constant communication with the Attorney General's office because we knew this transaction was taking us longer than we had anticipated. So there is probably something we could work out together.
Now is probably a good time to take like a 5-minute break. And we'll discuss that. And then we're going to start with the public comment. We can sort of come back to the topic later on.
sure.
But otherwise I'm done with my questions. It's really that last one there that we need to figure out a solution to.
Very good. Thank you.
So let's plan to come back at 3 o'clock. We'll do public comment. And again, if anybody watching wants to sign up to provide comment, feel free to do so by typing your name in comments.
Do we know how long the approximate list is?
At this time, I think it's just the list that you guys provided. So I don't know how many there are. I think there's about 30 people.
Approximately 30.
Okay.
I think you said there's
So
30.
we'll come back. Thank you. Before we get into the public comment portion, I did just want to say one thing about where we left off on the OAG, FTC, all that. I just wanted to draw council's attention to 19A-639 sub D sub 2. So that says, in any deliberations involving a certificate of need application filed that involves transfer of ownership of a hospital, in addition to the guidelines and principles set forth in subsection A, you need to look at various things, including whether the applicant fairly considered alternative proposals or offers in light of the purpose of maintaining healthcare provider diversity and consumer choice in the healthcare market and access to affordable quality healthcare for the affected community, and also B, whether the plan submitted pursuant to 19A-639A demonstrates in a manner consistent with this chapter how healthcare services will be provided by the new hospital for the first 3 years following the transfer of ownership of the hospital, including any consolidation, reduction, elimination, or expansion of existing services, or introduction of new services. But really, we're looking at 2A, which that's the focal point, and that's sort of why I'm pushing back on us gaining access to that information. And if you have provided it to the OAG, if you have provided it as part of the CMIR, in my mind, there's no reason why you can't provide it to us either. As long as it's done in a confidential way, and in such a way that it wouldn't be made publicly accessible. So I'll leave it at that. We can talk about that a little bit more later on, but I wanted to plant that seed and you could think about it as we go forward.
Yeah, and if we could speak to that, I mean, it was addressed in the application and we can provide the reference in the bait stamp, in the completeness questions and in the underlying application.
We can, we'll get to that. I want to move on to the public comment portion because I understand that there are some elected representatives who are waiting to provide comment. And I don't want to hold them up any longer than necessary.
We agree.
So just as a reminder to everyone, this is the next portion of today's hearing concerning the CON application filed by Yale New Haven Health Services and Prospect CT, docket number 22-32542. We are just about done with the technical portion. So sign up for the public comment has been all day in person and on the Zoom and comment section. There were a total of 31 people pre-registered by the applicants. And to give a sense of how long we can expect the public comment to take. We normally limit commenters to about 3 minutes, with elected and appointed officials being granted some flexibility on that 3-minute limitation. So assuming each of the pre-registered individuals speaks for 3 minutes and no one else signs up, that's still about 1 hour and 30 minutes of comment. We do have one member of the public who signed up. Her name is Michelle Payton. So she will go somewhere near the end, probably after all the other pre-registered individuals. We will call the names of those who signed up to speak in the order in which they registered. Afterwards, I will ask if there is anyone else present who wishes to be heard. As I mentioned, speaking time is limited to 3 minutes, and I'm going to pretty strictly enforce that because I do want to try to get through everybody in as quickly a fashion as possible. We do, if you haven't signed up, or if you're not able to provide public comment today, we do encourage you to submit written comments by email to ohs@concomment@ct.gov. And to the best of your abilities, anyone who's providing comment should try to limit duplication of comment. You know, after a certain point, it becomes like no longer helpful to just hear the same things over and over and over again. So if there are specific things that would be helpful, that's really what we want you to focus on. So I thank everyone for taking the time to be here today. We're now ready to hear statements from the public. We're going to have first Mayor Neil O'Leary. Is he available? You could right on here too, sir. Thank you. Right, whenever you're ready.
I am ready.
The camera is right there, so if you want to speak to them, you can do that. If you want to speak to us, that's fine too.
Try to speak to everyone.
Okay.
Good afternoon, everyone. I just want to thank the Office of Health Strategies for hosting this meeting today for the CON. My name is Neil O'Leary. I've been the mayor of the city of Waterbury for nearly 12 years. Employed by the city of Waterbury for 43 years. So I've been around for a little while, have a little history I'd like to share with you regarding Waterbury Hospital, and I'll get to the reasons why. In 1980, there was a very contentious strike with 520 nurses walking out, which that strike lasted 3 months. 1986, there was another strike that lasted 4 months. In 2013, there was another strike that fortunately only lasted less than a month. The only reason I bring all this up is because we've had this history of issues in our city. Fortunately, we have two hospitals. We have Waterbury Hospital, we have Trinity St. Mary's Hospital, one Catholic, one not Catholic. And there's been some contentious issues over the years involving Waterbury Hospital. Much of it, of course, involved with labor, organized labor. And in 2016, there was a Prospect Medical came across and said, listen, you know, the hospital was in a financial crisis. It was well publicized. Prospect Medical came in and purchased the hospital, went from a nonprofit status to a for-profit status. And was a very anxious transition, quite frankly. But at the end of the day, I think most people would agree that Prospect, stabilized the finances of the hospital, infused over $50 million in capital to the hospital, was able to bring some sort of fiscal responsibility to the hospital. Labor relations didn't improve greatly, but they improved slightly, at least for a period of time. Quite frankly, we welcome Yale, New Haven Health coming into Waterbury Hospital. We were very pleased to hear that Yale was interested in acquiring Waterbury Hospital for so many different reasons. Our constituents in the community, we feel strongly will be better served with Yale, New Haven Health coming to town. I want to make it clear that from 2016 until recently, the quality of healthcare at Waterbury Hospital was strong. It wasn't like there was this lapse in quality of healthcare, but there was always this issue between labor and the hospital administration. And it didn't change when Prospect came in. It got slightly better for a period of time because the hospital was really in such financial straits prior to Prospect Medical Holdings coming in. And, we're proud to say that, Prospect did provide the services that they could during this period of time. And of course, we all know what COVID did to healthcare. We don't need to go down that path. But at the end of the day, the community will have access to world-class healthcare that's offered by Yale, including clinical trials for patients with cancer and rare diseases. We have so many of our people now who are being treated at the Harold Lieber Cancer Center, which of course is run by Yale, Smilo, as well as St. Mary's Hospital. But we are really welcoming the opportunity to see more healthcare services come into our community through Yale, so that a significant population of our people who are suffering from, and it's not the city of Waterbury, by the way, it's the region, as you well know, suffer from very different and significant cancers that, quite frankly, Smilo may or may not be able to handle, but so if they can't, they have to go to Haven. And that is a huge lift for some of our people, especially our elderly population. We are thrilled to have the stability. That's why I'm here. The stability of an organization, world-class organization in healthcare that's known across the planet in healthcare. And the stability to provide the services to our constituents in every area. And I'll remind you that it was 2004 that I sat and testified as police chief, begging for OHS and the State Department of Public Health to allow the city of Waterbury, both hospitals, St. Mary and Waterbury, to allow angioplasty procedures. Prior to 2004, we were putting people in ambulances every day to go down to New Haven and Hartford for angioplasty services. I don't want to tell you how many people didn't make that right. It's been a long march back, and we look at this transaction as the benefit of healthcare to be provided in the city of Waterbury. That's how important it is to our constituents. I look at it, my entire life in the city of Waterbury, in the last 43 years with the city of Waterbury, as the most significant opportunity this city has seen since I've been here. And I really mean that from the bottom of my heart. And we're proud to have Yale so interested in our city and our region. Thank you.
Thank you, Mayor. Next on the list is Representative Ronald Napoli Jr. Is he in person or available via Zoom? Let me just confirm that unmuted. So Representative Napoli, I guess, is not here. If he shows up, you can just make a statement whenever he becomes available. Just try not to interrupt, just, let us know in between, individuals, and we will try to take him. Representative Geraldo Reyes, is he available? Same thing for him. If he becomes available, we will take his statement. Representative William Pizzuto.
Yes, sir. Try to be brief and not repeat what my honorable mayor has said. Good afternoon, everyone. My name is William Pizzuto. I'd like to thank the honorable ladies and gentlemen of the Office of Healthcare Strategy or Health Strategy for the time and consideration you've given us with regards to the transfer of ownership and the application for Prospect, Connecticut hospitals to New Haven. And so very briefly, by way of my background, not to bore you, I have a PhD in adult and technical education from UConn. I'm a member of the Connecticut General Assembly representing the 71st District, which is Middlebury and Waterbury. And I'm a long-serving member of the Hospital of Prospect Waterbury Local Advisory Board. I'm a former director of the UConn campus in Waterbury and former chairman of the Greater Waterbury Chamber of Commerce. I served as an alderman under different mayors, and I was a former police and fire commissioner as well. And I bring all that up only to show you my connection to the city and to the hospital. It runs very deep. While at Waterbury UConn, we added an allied health program. That was a program that was only offered at stores. And the reason we did that is quite often our students are placebound, but it gives them entree into the PA and the APRN world, which is wonderful. It's because of hospitals such as Waterbury and Yale working together that supported the higher ed opportunities for the students to have these opportunities to go on besides being placebound. They don't have to travel to New Haven or the stores. In my opinion, Yale's the perfect entity to obtain Waterbury Hospital as they have a long-standing relationship with the doctors, the staff, the faculty, the students in Waterbury. Yale brings expertise, opportunity, state-of-the-art everything to a population that would benefit tremendously from this transfer of ownership. On a personal note, my family and I have a long history of Waterbury Hospital. I was born in Waterbury. My children were born in Waterbury Hospital. All my grandchildren were born there. We've had major surgery there. Everyone I know that's been as friends, family, or either patients or have friends that were patients. In that 133-year history in Waterbury, thousands of people were born and have been patients there. And literally thousands have worked at Waterbury Hospital and Waterbury Health over the many years to provide for their families and to provide for the necessary health care so critically needed in our urban area. I strongly believe that Yale's the right organization to take over Waterbury Hospital. I support this change of ownership as it will allow more residents to receive high quality care closer to home and enhance access to world-class tertiary and quaternary care and clinical trials. I think the mayor mentioned that as well. The proposed acquisition will preserve jobs, even grow jobs. Healthcare is important to Greater Waterbury, not just for patient care, but as a source of medical related jobs, which have tremendous spin-offs in other related areas and careers. This is an incredible opportunity for our fine city and for the residents of Greater Waterbury and beyond. For these reasons and many others, I respectfully ask that you approve the certificate of need application. Thank you very much.
Thank you, Representative. Next on the list is Senator Joan Hartley. Is she available either in person or via Zoom? Okay. If Senator Hartley becomes available, we will take her in between one of the next people. Senator Anwar, is he available?
Yeah, I am on Zoom. Good. You guys can hear me, I hope.
We can, there you are. Okay.
Okay. All right. Thank you so much. Good afternoon, everyone. I'm Senator Saud Anwar. Honorable members of the Office of Health Strategies, thank you for giving me the opportunity to share my thoughts and my enthusiastic support for this CON. I'm a physician, a pulmonologist, and an intensivist. I've been in this community around Manchester and the greater Manchester, greater Hartford area for some 25 years. And have taken care of our patients with lung diseases and intensive care unit, the ones who have been critically ill. I am not employed by ECHN, but I'm affiliated with the ECHN. I want to share my enthusiastic support, and I want to give you some reasoning that I feel is important to consider. First and foremost, we need to recognize there are about 300,000 people in this area. I'm not mentioning the Waterbury area, but more so the east of the river community. There's a large population that is dependent on the health and well-being of this healthcare system. So we have a responsibility to have a sustainable healthcare in this community. The challenge with private equity is that sometimes private equity and health equity do not go together. As I'm sure many of you are aware of the private equity issues that we have heard with the same organization Prospect in Rhode Island and Pennsylvania, we have to make sure that we protect the community that we serve. I was trained at Yale. I spent my training in pulmonary medicine, critical care medicine, and also did my master's in public health at Yale. Yale is going to be a blessing for the community. This community needs a high quality group of healthcare workers and also the support and the background that Yale would bring to this community. Another thing that I think is worthy to mention is that Yale is willing to provide care to individuals who are 250% of poverty level, the federal poverty level, which really increases the number of individuals who will benefit from this acquisition. And again, the workforce needs that we have across this region, Yale is a natural fit to be able to create seamless transition of workforce that they're creating to be part of the workforce that are needed over here. And I have multiple other reasons, but I'm going to leave it at this in the interest of time to say, please consider this. There are so many families in our community in this region that are hoping that this will move forward. There are patients who are hoping for this. You would be surprised how many patients call and say, are we going to be able to connect with the Yale support system? And the answer to them, I say, is we are very hopeful that the right decisions will be made by the Office of Health Strategies. And I urge you to make the right decision. And thank you for allowing me to share my thoughts. Thank you.
Thank you, Senator. Next on the list is Mayor Bob Chatfield and then Mayor Jay Morin. So starting first with Mr. Chatfield, is he available? Okay. How about Mayor Jay Morin?
Good afternoon. This is Mayor Jay Moran of the great town of Manchester, Connecticut. Sorry for the dark background. Without repeating my good friend, Mr. Mayor O'Leary of Waterbury and the reasons of closer home health care, the quality of Yale and the world. Sorry about the Zoom. I'm here to support this application and for several reasons. One, I'm so proud of the staff and the doctors and nurses and everyone that works at Manchester Memorial that serves our community, especially through COVID. They did so much. They were true heroes, and I can't say that enough. But the importance of a local hospital and connecting with Yale, as Mayor Larry said, is the best word is stability. and that stability for years to come, offering quality health care and preserving jobs right here in Manchester. I've told this story to some of you before, and if you've heard it, I apologize because I've sat in front of these several times in my 9 years as mayor. You really learn the importance of local hospitals when you're set in that emergency situation. It was in February 14th, 2001, when my daughter, who was less than 2 years old with battling Hurler syndrome, went into pulmonary arrest. And I'll never forget what the ambulance driver said. He said, "Mr. Moran, we're going to go to Connecticut Children's Medical. But if we get outside your driveway and realize we're running out of time, we're going right to Manchester Memorial." That's when I truly understand how local hospitals were so important to saving lives. I also can tell you it was a convenience for our family during some of our roughest times. Instead of traveling to Hartford every day when she had to have her platelets checked, Manchester Memorial came to us and said, "You have the blood done here." So we didn't have to drive to Hartford, find parking. It was such a convenience. So I support this merger. I think it's so important. My four children were born at Manchester Memorial Hospital. I'm so always been proud of that hospital, looking for this stability and this relationship with Yale. I was not trained at Yale like my good friend, Dr. Syed Anwar, but I'm a graduate. I was born there 60 years ago. So I'm so proud of everything. And I appreciate the time. I encourage you to improve this application for the betterment of so many people in Manchester and the surrounding area. Thank you for your time.
Thank you. So there were a number of other individuals that were pre-registered by the applicants. I'm planning to just take those in the order in which they've been listed. Is that okay with you?
Sure.
Are there any other elected or public officials who haven't spoken yet, who wanted to make a comment? Okay. Hearing none, we're going to move on to Kyle Kelly of Naugatuck Ambulance. Is he available? I'll call out the next three. That way, you know who's coming. It's Lynn Ward, John Hopkins, and Angie Mathis. Is Lynn available?
Hey, how you doing? This is on behalf of Lynn Ward. My name is Stephen Del Vecchio. I work at the Waterbury Regional Chamber as the Government Affairs and Economic Development Director. Unfortunately, Mrs. Ward could not make it today, but I'll be reading her testimony on her behalf. Can everyone hear me okay?
Yes.
Okay. Dear Dr. Gifford and honorable members of the Office of Health Strategy. As President and CEO of the Waterbury Regional Chamber of Commerce, I am writing to express our strong support for Yale New Haven Health System's proposed acquisition of the Assets Prospect Medical Holdings operation in Connecticut, including Waterbury Hospital and the Waterbury Health Network. Our members and the larger community will be much better served by this proposal. We support the proposed transaction because it will allow more residents to receive high-quality care closer to home and enhance access to world-class tertiary and quaternary care and clinical trials. In addition, it will revert these assets to nonprofit, ensuring that capital and other investments remain in the community rather than being distributed to shareholders. The proposed acquisition will also preserve jobs and stabilize key local assets. Through the years, Yale New Haven Health has been a valuable partner to its local communities. Further, Yale New Haven Health has delivered on its promises with past affiliations, including numerous clinical investments at the Hospital of St. Rayfield, now a campus of Yale New Haven Hospital, Lawrence and Memorial Healthcare, together with Westerly Hospital and Milford Hospital, now a campus of Bridgeport Hospital. Representatives from both organizations have completed extensive due diligence and concluded, along with their respective board directors, that this would be the best outcome for both institutions and the communities they serve. We agree. On behalf of the Board of Directors and 900 chamber members, we strongly encourage you to approve this application. Sincerely, Lynn G. Ward, President and CEO of Waterbury Regional Chamber. Thank you for your time.
Thank you. Next on the list is John Hopkins. Is he available? Angie Mathis. All right, the next three.
Coming up.
Oh. Who was that?
Hi, good afternoon. I'm Angie Mathis. I'm the Executive Director of Greater Waterbury Health Partnership. Thanks for inviting me to say a few words to the members of the Office of Health Strategy and also to Dr. Deirdre Gifford. So I'm happy to be here today to just give a little background, but first and foremost, to offer my strong support of this acquisition between Yale, New Haven Health, and also Waterbury Hospital, Waterbury Health. I want to kind of just give a little background, right? Waterbury Hospital, community hospital since 1890, offering unparalleled health care to the members of this great community for over 125 years. And that's important, right? Because my organization, Greater Waterbury Health Partnership, builds bridges between the healthcare system here in Waterbury, and that's done through collaboration. And so I thought I could take a moment first to just describe our mission, which is that Greater Waterbury Health Partnership aims to provide access to culturally sensitive and evidence-based health information for the Greater Waterbury region, and we coordinate local healthcare services to improve overall community health. Supported by data, our mission is rooted in community collaboration as a critical element to meet the needs of our diverse communities. And I want to emphasize that collaboration because I strongly believe that it's been through the power of collaboration with GWIP partners and Waterbury Hospital that we've been able to accomplish great community benefit. And I can foresee the future a little bit, right? That this wonderful pending acquisition, which I strongly support between Yale and Waterbury Hospital, will only develop and enhance that community collaboration that is enhancing the health and the livelihood of so many of our community members, which as you, if you work in this community, you know, are suffering from great health disparities. And so some of the things that we've worked with Waterbury Hospital on from the standpoint of community benefit have been the community health needs assessment, which is posted on our website and other hospital websites in our area. We're in the process of doing the community health improvement plan now. We run something called a community care team, which is a clinical and community-based organization integration project, which really takes a look at some of our most in-need patients that are utilizing both hospitals in the area, and we collectively case manage them so that they have better outcomes and can become independent and productive members of this community. We also run something called the Waterbury Health Access Program, which is housed in Waterbury Hospital. So we have 2 LCSWs and 8 community health workers and case managers over there collaborating daily with the emergency department. And we hope and really are looking forward to that continued collaboration. And then I just wanted to kind of say a couple words about Dr. Justin Lundby and his commitment to the community and how wonderful that's been as really a strong advocate for our work, but also for this community. I've seen firsthand how he really gets at the neighborhood level, and specifically during COVID. When I myself went through a large vaccination line at Post University, Dr. Lundby was out there with his staff doing whatever it takes to make sure that the community is safe and healthy. And so that's really the spirit of Waterbury Hospital, right? For over 125 years, meeting the community where they're at and developing relationships. And so from that standpoint, I strongly really support this acquisition today, and really am honored to be here and be asked to speak on behalf of our collaboration with Waterbury Hospital and hopefully our continued alignment work in community benefit with Yale New Haven Health. Thank you.
Thank you, Ms. Mathis, excuse me. Kristen Jacoby. Is she available? Okay, the next 3 are Leslie Swiderski, Angela Holmes, and Tony Bocci. So starting first with Leslie Swiderski, is she available?
So on behalf of Kristen Jacoby, President and CEO of United Way of Greater Waterbury, I, Jared Cruz, as Chief Impact Officer, rise in support of the acquisition. I'm excited about the great opportunity that this acquisition will have and the impact it will make on our community, especially those most vulnerable in need of excellent quality, world-class care now more than ever. I've seen firsthand the great impact that Yale has had on the homeless response system in the greater New Haven area. And as a United Way, we are committed, deeply committed to the support of the homeless and those in the Alice community. Yale will bring a level of support and expertise to the table that will ensure that those in most need, including potentially medical respite programs for the homeless, which are offered in New Haven, can come to the forefront here in Waterbury. We, as United Way, are excited and look forward to the acquisition to come to fruition.
Thank you. So I believe Kyle Kelly, who was the first on the list, I saw his name pop up. Is he available?
Hi, hello, can you hear me okay?
Yes.
Hi, thank you, I apologize for that. I would like to speak up on behalf of the acquisition. Naugatuck Ambulance here is very excited for the gain of Yale New Haven Health to the area. We are extremely grateful for the help Waterbury Hospital has afforded us in the EMS world as well as the region over the past several years and the last several months here. We have been working on many great strides to better our service together. And I believe with the acquisition that will just help us do that much more and be stronger together as we are stronger with numbers. We're looking forward to many more great collaborations with Yale, and we're happy to be a part of this, and we look forward to it.
Thank you. Angela Holmes, is she available? Tony Bocci. All right, so next three on the list are Ariana Washington, Dr. David Hill, and Dr. Duncan Belcher. So starting with Ariana Washington. Dr. David Hill.
Good afternoon. I'd like to thank the Office of Health Strategy for giving me the opportunity to testify. I am Dr. David Hill. I'm a pulmonary and critical care physician who has practiced here in Waterbury for over 25 years. I've been an attending physician at both Waterbury and St. Mary's hospitals for my entire career. And prior to coming to Waterbury, like my friend Dr. Anwar, I completed my postdoctoral pulmonary and critical care fellowship at Yale. I've served as a Yale faculty member for the entirety of my career, teaching medical students and residents in my office and at both local hospitals. I also hold the voluntary position of chair of the Prospect Waterbury Advisory Board. This gives me a unique insight into the difficulties facing community hospitals. As a physician and a healthcare leader, I have witnessed our healthcare system change over the course of my career. The practice and business of healthcare delivery has constantly evolved and is particularly challenging in communities such as ours, which have a high proportion of patients with Medicare and Medicaid as their primary insurance. As a not-for-profit health system, Yale New Haven maintains a strong commitment to serving patients and the community. Similarly, as a community hospital, Waterbury Hospital and its network has a long history of serving patients and our community. The proposed acquisition of Waterbury Hospital and Waterbury Health builds upon the strengths of each hospital, and will integrate the resources of Yale New Haven Health to improve the healthcare of our community and our region. It will allow for improved local access to academic medicine while preserving jobs. Waterbury Hospital and its affiliated network and the greater Waterbury community will be stronger following this transaction. The transition of Waterbury Health to Yale New Haven Health System is an important opportunity to meet Connecticut's ever-changing healthcare needs with exceptional, high-quality care. As a longtime practicing physician in the greater Waterbury community, I am keenly aware that healthcare has evolved and changed, especially following the COVID-19 pandemic. I believe that this transaction will benefit my patients, benefit the community at large, and that is why I strongly urge you to support it. Thank you.
Thank you, Doctor. Next on the list is Dr. Duncan Belcher.
Good afternoon, and thank you for having me. I'm Dr. Duncan Belcher. I'm currently Waterbury Hospital's Chief of Staff. I've been a practicing interventional radiologist at Waterbury Hospital for the last 26 years. For 13 years, I was the chief of the Waterbury Hospital Radiology Department. I'm also the managing partner of Diagnostic Radiology Associates, my physician radiology practice that has been serving Waterbury Hospital since 1974. I'm here to say that I strongly support the proposed acquisition of Waterbury Hospital by Yale. The transaction will have many positive outcomes for the quality of healthcare in the Waterbury community. We'll have access to world-class quality and safety practices that an institution of Yale's scope can bring. Patients with more complex medical problems needing treatment both here and in New Haven will have the benefit of their medical records being in a contiguous, seamless network. That's something we see very positively in our practice because there's a lot of oncology patients who get treated both here and in New Haven. It's very difficult to make sure that you're seeing their most up-to-date CAT scans or MRIs if they're going back and forth between the two cities. Work out separate systems, that will be a great improvement. One misfortune of the COVID pandemic has been the impact on healthcare workers. Like many health systems, Waterbury has seen the egress of many experienced professionals due to early retirements, burnout, people opting for less stressful occupations. I'm confident that the proposed transaction will help us recruit and retain much highly needed, highly qualified healthcare professionals into the community. Finally, I do have a friend and former residency colleague who is a radiologist at one of the community hospital Yale's network. He has remarked to me frequently in the last few months that the best thing that ever happened to their institution was when Yale took over the administration. I'm confident that if this transaction is approved, I'll be saying the same thing in a year or two. Thank you for your time.
Thank you, Doctor. The next three are Trish Gentile, Michelle Diaz, and Addie Geary. So starting first with Trish Gentile. Is she here? Okay. If you could just let me know when she comes back, or did she exit this room, or did she? She's in the holding room. Yeah, okay.
Do they have the ability in the living room to come on Zoom?
They should. Yeah. No?
Not from Zoom, they can just walk. They went to get.
Hi, Dan. Trish is in here, but she submitted written testimony, so she's not going to be giving public comment.
Okay, thank you. That was Lady Ventus. She's the one in the other room. Next is Michelle Diaz. So
This is May again. Michelle's also in this room, and she submitted written testimony, so she will not be giving public comment.
Okay, thank you. Addie Geary. So Zoom from Waterbury. Next three on the list, Dr. Neil Schiff, Yarixa Lopez and Dr. Kyuku Sam. So first, sorry.
It's Addie Derry.
Oh, Addie?
Hi,
Hi, sorry.
thank you. I wasn't prepared to be speaking today, so I'm just gonna speak from the heart. My name is Addie Carey. I'm one of the nursing directors at Waterbury Hospital. And I'm here to fully support the acquisition with Yale New Haven Hospital. I grew up in Waterbury Hospital. I was born there. I live in the community right next door. And Waterbury Health has been the #1 choice for my family for all of their healthcare needs. I was hired by Waterbury Hospital at the age of 19 as a PCA, and I transitioned over the years. I've been there for 21 years, and I transitioned from a PCA to a student nurse, to a nurse, to a manager, and now as a nursing director. I oversee all of the cardiology services at the hospital. I'm very particular to Waterbury Hospital. I think we provide high quality care to all of our patients. I'm particularly in support of the acquisition for the cardiac services that Yale New Haven Hospital can provide. We are looking to advance our cardiac services at the hospital. So we are, looking to be able to provide a lot of cardiac services to our community. Right now, we have to send some of our patients out to either Yale, Hartford, Griffin Hospital, which we can easily, hopefully do right within our community. Our patients and their family would have to travel probably over half an hour away to get these services and some of these advanced cardiac procedures that we don't offer now. So I'm in fully support of the transition, just in the fact that we can provide better cardiac services to our community within the Waterbury area. So thank you.
Thank you. Next is Dr. Neil Shipp. Yarixa Lopez.
Yes. Hi, my name is Jadon Lopez. I am a human resource business partner.
We can't hear you, Ms. Lopez.
Can you hear me now?
It's better. Can you speak up a little bit more?
Yes, of course. My name is Jadon Lopez. I am a human resource business partner for Waterbury Hospital.
We're having a hard time hearing you.
Okay.
Are you able to call in using a different laptop or your phone? I also can't hear you. I don't know if you're.
I did submit my statement, so I'm okay with that.
Okay. Sorry about that. It's one of the pitfalls of technology. Dr. QQ Sam. The next three on the list are Dr. Joey Cosgrove, Carl Cantadini, and Dr. David Pizzuto. So starting first with Dr. Cosgrove.
Good afternoon. I'm Joey Cosgrove, and I'm the medical director of the intensive care unit at Waterbury Hospital, and I also serve as the chairman of the Department of Medicine. I serve as a faculty member of the Yale Waterbury Internal Medicine Residency Program. And additional leadership roles include being a member of the Staff Executive Committee and of the Prospect Waterbury Board of Directors. Thank you to the Office of Health Strategy for your time and consideration you have given to the transfer of ownership application from Prospect, Connecticut to Yale New Haven Health. As a pulmonary and critical care physician, I have served patients in the greater Waterbury area for nearly 20 years. Waterbury Hospital is vital to the health, the quality of life, and the economy of this community. We provide care to the sickest patients in our community in our ICU. We are able to provide high quality care for these patients close to home. This allows families to be engaged in the care of their loved ones, which we feel plays a major role in their healing. I believe a transition to a Yale New Haven Hospital is in the best interest of our patients and the community. As a faculty member of the Yale Waterbury Internal Medicine Residency Program, I play a part in training the physicians of the future. The Internal Medicine Residency Program is the hospital's largest residency program with about 30 residents and one of its oldest programs with over 3 decades of experience. Much like Yale New Haven Health, the Yale Waterbury Internal Medicine Residency Program is affiliated with the Yale School of Medicine, one of the best academic and research institutions in the country. As a community hospital, it is our responsibility to train the new generation of physicians, and our internal medicine residency plays a significant role in this. I support the proposed transaction for our patients. A transition to Yale will allow our patients to receive high-quality care close to home while giving them access to world-class tertiary and quaternary care and clinical trials. As a Yale hospital, we will continue to maintain our community hospital legacy. I urge you to approve this certificate of need application, allowing Yale to take the ownership of Waterbury Hospital. Thank you.
Thank you. Next on the list is Carl Cantadini. Excuse me.
Close enough. Good afternoon, everyone. My name is Carl Contadini. I'm a resident of Goshen, Connecticut. And I've been associated as a volunteer at Waterbury Hospital for over 25 years. During that time, I served as chairman for 6 years and was, as chairman, started a pursuit for a capital partner because of the situation Waterbury Hospital was in, and that was in 2011. After 2 failed attempts and working with other networks within the state of Connecticut, we could not find a capital partner. Prospect Medical came along and made us a proposal that said, we can help you, we can help fix your problem. We started on that road 7 years ago. We were here at the Marriott and we were advocating for the approval of the Prospect and Waterbury purchase. During that period of time and over that 7-year period, we've made a tremendous amount of progress at Waterbury Hospital. I still sit today on the advisory board. I get to review all of the statistics and the hard work that has been done at Waterbury Hospital. We continue to see the key performance indicators on a positive trend. We've also received over $60 million in capital expenditures to the hospital. And that alone has bred new life into this organization. All of this was made with a lot of hard work under Dr. Lumbais and his staff have done a lot of heavy lifting these last 6 years. That heavy lifting has allowed us to become what I consider a very attractive asset for a possible purchase. 7 years ago, when we signed and inked the papers with Prospect Medical, we knew in 5 to 10 years that we would be back here again, looking for approval for a new partner. That's the life of private equity. The only thing that we didn't know back then was who was it going to be. Well, we know who that is now. And as I must say that we are excited about the opportunities. This will help us to improve patient outcomes. It'll allow us to continue to hone all of the skills that we learned on the Prospect. And we will be able to have additional patient access and the ability to have state-of-the-art medical care here in Waterbury. Waterbury Hospital, just for your information, last year we did 44,000 ER visits. We had over 65,000 patient days at Waterbury Hospital. So if you look at that and you look at those numbers, you can see the importance Waterbury Hospital is to this community. With Yale at our side, working with us, looking at best practices, we believe the future is bright for that hospital on the hill. I ask all here today to get behind this transaction, for it is a generational opportunity to transform healthcare here in Waterbury for years to come. I'd like to thank you for giving me this opportunity to speak about my hospital. Thank you.
Thank you. Next is Dr. David Pizzuto. Is listed as Zoom from Waterbury.
This is Faye. He also submitted written testimony.
Thank you. The next three I have, I believe this is the last three. Steve Delvecchio, Dr. Robert Rodner, and Molly Devaney. And then we have the one right in.
Unfortunately, Russ will go ahead.
Let's start with Steve Delvecchio. Is he available?
Did you read the testimony of Lynn Ward earlier?
Oh,
Or is the president and CEO of Waterbury Chamber?
okay. Dr. Robert Rodner, is he available?
Yes, I am.
Okay, doctor, you can speak whenever you're ready.
I'm a resident. I'm a resident of South Windsor, and I'm very much in support of the proposed acquisition of Manchester Memorial Hospital and Rockville General Hospital by Yale New Haven Health System. As a consumer of services from both health systems, as well as a retired 40-year practitioner at Eastern Connecticut Health Network, I can see how the transition back to a nonprofit will better serve my personal health needs and the greater Eastern Connecticut community. The accessibility of the two ECHN facilities paired with a well-recognized world-class medical system is laudable. As my family's need for tertiary healthcare services burgeoned, I became increasingly more familiar with Yale New Haven's clinical offerings, their level of medical excellence and superior customer service. The promise of incorporating those qualities back into our region is highly desirable and very enticing. I am aware that healthcare delivery is becoming more consolidated and less competitive. Yet it takes a strong, well-run, and well-financed system to provide the level of medical and digital technology we expect and require from our medical providers. Adding Yale New Haven Health into our mix of providers can only enhance our quality choices and instill a healthier competitive environment. We have experienced a disappointing adventure into the for-profit world in which maximizing profit meant limiting local investment. Yale New Haven has demonstrated its commitment to its regional acquisitions of St. Raphael, Lawrence and Memorial, and Milford hospitals. Its success in our locale will only shine a favorable light on its ability to enhance regional care with strong tertiary and quaternary services readily available. I support this proposal because it will strengthen our access to world-class health care and improve customer service reverse the negative impact of a remote for-profit owner, and enhance the competitive climate of healthcare in our state. Thank you.
Thank you, Doctor.
I'm sorry, I believe we have had Senator Hartley has arrived. If you want to take that order.
Sure, I received a note on that. Senator Hartley.
Good afternoon. Thanks for allowing me to be here. Just kind of rolling over from the Capitol. And today we had Muscular Dystrophy Day. And so a lot of conversation about healthcare. So for the record, my name is Joan Hartley. I am the state senator from the 15th district. That's Waterbury, Naugatuck, Middlebury. And I first of all want to recognize the Office of Healthcare Strategy. I have watched all the iterations legislatively that have gone on, and my hat is off to you all. The work that you've done, and now under the direction of Director Gifford, and in particularly the diligent work of the now the HSP, the Health System Planning Unit. And your legislative charge, and this is obviously no news to you, but it is so important to all of us in the state, is the administration of the CON process. The primary purpose of that, which we know, is to ensure patient-centric, non-duplicative, quality, affordable, and accessible public health service systems in the state of Connecticut. And so pursuit and support of that mission, I am here to speak to you unequivocally in support of the application of the Yale New Haven property acquisition, proposed acquisition of the Prospect Medical Holding entity, which includes also Waterbury Hospital and the Waterbury Health Network, which I am very familiar with, having actually served as an elected official in that area for 30 years. And so you are all so very aware of the geographic area that we're talking about here. We're talking about a primary service area that's the city of Waterbury, 110,000 residents, and the secondary service area, which makes up about 203 approximately 1,000 residents, a total of over 300,000 residents. Just recently our health network identified this as being categorizing it as a large, very large health area, which obviously you all know and are familiar with the demographics of which many of them are seniors over 65. Many of them have transportation challenges as well to get to access health, primary health care. The approval of this transaction will ensure the residents of Waterbury and the greater Waterbury area, my constituents, family, friends, neighbors, and people I have represented, as I said, for over 30 years, with the distinguished and long recognized services that the Yale Health System has demonstrated over many years and in near many acquisitions and in other communities, not only just to patient care, but also to their employees and the communities in which they have invested themselves, investments in healthcare, clinical trials, infrastructure, and being corporate community partners. So I am here, first of all, to once again thank you for your diligence and your important work that you do, and also to support this application unequivocally. So if there are any questions, I certainly would entertain them. And I know it's been a long day. Maybe I'm hoping to end it up for you all. A long day in a small room, which, by the way, no one could find. That's what we're going to do over the LOB. We're going to put together maps so we can get you all here better. Thank you once again for this very important.
So we have two more people. We have Molly Devaney and then Michelle Payton. Starting first with Molly Devaney.
Good afternoon. My name is Molly Devaney. I'm a lifelong resident of Manchester, and I was born at Manchester Memorial Hospital 45 years ago in a couple days. Just wanted to, I'm honored to be here today to talk about Manchester Memorial Hospital and this opportunity with Yale New Haven Health System. This is just a wonderful opportunity for Manchester, and the people of Manchester and Greater Manchester will be better served by this. Absolutely. Community affairs is really my background, and I have had the opportunity to serve on the advisory board for Eastern Connecticut Health Network for the past few years. I'm honored to do that, and I see many advantages to Yale coming to the area. I see things going on at Yale University all the time and just think their ideas. I want to pull them. Like today, they had an awesome event going on. And I just, again, want to say like what they're doing as far as the community outreach and the community activities, I think go unparalleled to many systems that are out there. And I think that if we could bring that to people in the Manchester, Greater Hartford community in Waterbury, it would be very, just a huge benefit to the community. I honestly can't tell you how much I look forward to this possibility. I have a personal connection with Yale as my aunt's a patient there. I've traveled back and forth to the Adler Center many times because I cannot get the care locally. It's something that I am completely impressed by the Yale system. They've gone above and beyond for my aunt. When we sat there and we talked to the social workers and the care teams that look after her, it's what a difference in the care that you receive at Yale versus the care in the community. In not that we're not doing what we can, we're doing what we can in a community-based hospital. I can't say enough about my commitment to the community-based hospital, but I also think that this partnership with Yale would just make it such a more significant care to the community involved. I think that seeing the care and the social workers that breaks things step by step on what to look for and what you can do and what you can't do in the possible connections that you can make. I just think they have the ability to give you more. I can't say enough. I really researched and took my time trying to find doctors and the right fit, and Yale University was by far blew everybody out of the water. I really encourage you to approve this application because I think this is something that our community needs, and we would be completely better off with the Yale University New Haven Health System becoming part of our community. I thank you for your time, and I would really appreciate that you would encourage to approve to support this application today. But my family business is here in our town. I'm not going anywhere, and I would love to see the care for my employees as well. It's something that my employees are always looking for questions and comments. They're coming into our offices. We have an open door policy with our family, having a family business. My 3 stores, I have over 500 employees, and we're always trying to get them the best care and try to help them. And, we're constantly using the services in our communities. And we just think that this would be a better fit for our families of the people we care. So thank you for your time. And I really appreciate you just listening today.
Thank you. And lastly, I believe we have Michelle Payton through Zoom, if she's still available. Oh, there she is.
Thank you for allowing me a moment to speak. I actually had you guys on all day and I was listening, and I decided last minute that I wanted to share some information. I have worked at Yale New Haven for 25 years, and I've heard people talking about how great it's been working at their local delivery networks, their facilities. I completely agree with the people that I work here with. I would want no one else to take care of my children. But I'm actually speaking as a mom from Beacon Falls. So I'm actually closer to the Waterbury Hospital than I am to Yale. And when my daughter was little, she had passed out at the dentist, and the EMS refused to take us down to Yale. We had to go to either Waterbury or St. Mary's. So when a couple of years ago, she was 20 years old, she actually ended up with cerebral venous sinus thrombosis. It was actually quite life-threatening for her. And I refused to call EMS. I actually put her in my car and drove her down to New Haven because I just refused to bring her to one of the facilities near where I lived. So I greatly appreciate Yale coming up because I would like my family to have that access. By the time we came down to New Haven, her images showed she was actually bleeding into her brain. She was lucky that it wasn't even a few more minutes later. We would have had to have surgery. Thankfully, she is graduating college this year, but I can't wait for Yale to actually acquire a delivery network that is near my home. I have a 1 and 2 year old at the house, so we will be using more services as the years continue. So thank you very much. I really appreciate the opportunity.
Thank you, Ms. Payton. Did any of the people that I called earlier who haven't given statements, have they arrived? Are they available now? Okay. I want to take just like a 2 or 3 minute break to discuss a few things with the OHS staff. And then we'll probably take a little bit longer of a break after that to hone the late files, and then we'll address the late files and do any closing remarks at that time. So I think probably everybody can just stay put. We'll be right back. Just a reminder, the video will remain on, the sound will remain on, so but the recording will be on. This is the hearing in docket number 22-32594-CON regarding the transfer of ownership involving Yale New Haven Health Services Corporation and Prospect CT Inc. My understanding is that there were some members of the public who attempted to sign up, but experienced some difficulty doing so. They appear to be on screen now, at least some of them. So we're going to accept into the record their statements now. If they can all just identify themselves, I would appreciate that. We're going to start with the gentleman on the left, I believe. We can't hear you, sir.
You're on mute.
I believe you're muted. I think you're muted on your end, so there's nothing we can do on our end.
We can ask them to unmute themselves. It'll pop up like it did for us. But she asked us to view the show on the camera. But go to that. I'll be more something. I'll pause for it.
It's not one of our names, no. It's not one of our-
Can you unmute your video? Can you hear us, I guess, is another question. Okay. We are unmuted.
There.
No, you are not.
This is that. And unmuted. This is unmuted. Yeah. We said we just can't hear you.
Okay. Well,
Maybe they could call in on a phone and use the phone for audio.
can you do that? Can you call in on a phone? And just use speakerphone? Well, we will still be able to see you. You'll just, the audio component will be through your phone.
If they can hear us.
They can hear us.
We will try. Just send the dialing number. See that?
While we try to sort this out, is there anyone else who wanted to provide comment, but who didn't have an opportunity? If so, please put your name in the comment box on Zoom.
Pastor Senate.
Yes, hi.
Okay.
Thank you for
Pastor,
taking,
if you can just state your name.
yes. Pastor Paul Sinnott, Sinnott.
Thank you.
I'm a retired associate to the bishop for the New England Synod of the Evangelical Lutheran Church in America. And I speak on behalf of 77,000 Lutherans here in New England. And I'm very much in favor of the buyout for a New Haven health system. New Haven Hospital has been providing a very robust clinical pastoral education program for hundreds of aspiring pastors through the years here in New England, and they've done an exceptional job at that. It's my hope that in this buyout situation that the CPE students could also work in some of these regional facilities where there's a great need, as there is everywhere, for spiritual guidance on the part of the clergy who are invited in to see their parishioners, who provide that kind of spiritual guidance and assurance for people who are in a crisis situation in the hospital. And almost everybody who is in the hospital is in some kind of crisis. I also am part of the Naugatuck Valley Project. And one of the things we've long advocated with Prospect is that we have a robust community benefits agreement. And that has not happened. I understand that Yale New Haven Health has one for Yale New Haven Hospital. And I would like to see that happen in our region as well, moving forward. And to have Naugatuck Valley Project and our union representatives be represented on some kind of a community board that would be able to address some of the concerns that those groups have. So thank you again. It's been a long day for you guys, all of you. You've done a really good job. I was on this morning and watched all of your detail work. And this public hearing has been the result of all that effort and attention to fine print. So thank you very much for your time.
Thank you, Pastor. So we're going to go back to the ECHN group again, if possible. Can you try speaking? We'll see if we can hear you.
Videos muted, they have phones. They have a dial-in.
Have you dialed in yet on your phone?
Were you the 203 number or the current 401 number? They can't. Yes or no question.
You only have one number at a time.
Hexadecimal. They had 203, they just hung up. They were just here, I saw them. They were muted on the 203 number. The 203 number.
This is the most polite group trying to.
That's no.
What's that?
That's our mill group.
Oh, that's.
Can you hear us now?
Yeah.
All right.
So are each of you going to be providing a statement or just one of you for the group?
Can't understand what you're saying. Here, there's two ends.
You're one of us.
The host muted you.
Did you hear us?
Yes. Okay.
You can hear us now?
Yeah, yeah.
Go ahead.
Good afternoon. Thank you so much for allowing us to speak on behalf of the transaction that Yale is proposing for Prospect Holdings. My name is Ellen Solomon. I'm a Senior Accreditation and Regulatory Affairs Specialist with Yale New Haven Health System. The Milford campus has always been an integral part of the Milford community. At the time of the integration 4 years ago, I was at a 25-year history with the hospital and a lifetime in this community. The integration with the Yale Health System and Bridgeport Hospital provided the Milford campus the resources necessary to continue providing care to our city and the surrounding towns. In addition to financial resources, the main campus of Bridgeport Hospital provided us with seasoned leadership who guided us successfully through the transition and melded the cultures of both campuses. We just completed a successful joint commission survey where the staff are fully engaged. And as my career sunsets, I am so proud that I am able to remain here at the Milford campus, provide healthcare to the community with the help and resources of the entire Yale Health System. Thank you very much for your consideration.
Hello, my name is Dominic Busetti. I'm a manager of environmental services at the Milford campus of Bridgeport Hospital. At the time of integration in 2019, I've been with Milford Hospital for 26 years. Like a lot of my coworkers, I was a little skeptical and didn't know what to expect. What I learned, it's been a great fit. Although we're 9 miles apart, we share a similar culture as Bridgeport Hospital, and that feeling of being part of a team has continued to develop. Before the integration, the Yale New Haven Health System and Bridgeport Hospital made promises to me and my Milford colleagues about keeping our longevity, our benefits, and our jobs. It's meant so much to all of us that they delivered on their promises and that Milford is thriving again. I support this.
Good afternoon. My name is Michael Rhea. I'm a carpenter and lead person in the facilities department at Milford Hospital, Milford Campus, Bridgeport Hospital. During my 45-year career at the Milford Campus, formerly Milford Hospital, I've witnessed a lot of changes. I think most impactful of these occurred during the last 4 years since we integrated with Bridgeport Hospital. In 2019, the facilities and engineering team was struggling to maintain and prevent the failure of outdated systems and equipment. Since then, Bridgeport Hospital and Yale New Haven Health System made significant investments in our physical plant and infrastructure. These mechanical upgrades contribute directly to staff and patient safety and include new boilers, chillers, the central sterile steam system, and new generators, to name a few. But the COVID pandemic convinced me of the value of our integration. To see our institution and system work seamlessly and safely to equip our hospitals and staff to take care of each other and patients was quite amazing. Recently, I've also noticed how busy we've become. It's good to see the patient rooms full again, and the operating rooms are busier than I have ever seen. The hospital is running like a well-oiled machine. Thanks to Yale New Haven Health System and to Milford Campus Bridgeport Hospital, everything is running like a well-oiled machine. I am in support of this acquisition.
Thank you to all three of you for your statements and your persistence. I don't believe OHS has, that concludes the public comment portion of today's hearing. I don't think OHS has any questions based on the comments that were made. We're going to take 20 minutes to go over the late files, and then we'll come back and we'll discuss those with everyone. And then we can do closing statements. We're also going to have to address the FTC RFP, that component as well. So let's come back at 4, let's just say 5, I guess. That will give us 25 minutes. So I'll see you back at 5, and then we will wrap things up at that point. Welcome back to the final component of the hearing in docket number 22-32594-CON. The hearing regarding the transfer of ownership of a healthcare facility involving Yale New Haven Health Services Corporation and Prospect CT Inc. We are at a point now where we're just going to go through the late file submissions. And then we, if either of the attorneys would like to make a closing statement on behalf of their clients, they're free to do so. So we're going to have Mr. Wong read them out one at a time. If you have any questions or concerns, or you wish to discuss them, please feel free to address them as he reads them. So we'll start with number 1.
Okay, Roy Wong, OHS. I have 11 total late files. The first is breakdown of cost savings. As mentioned, the 46 million at Lawrence Memorial and the 638 million at St. Rayfields, as described in some of the pre-file testimony. Breaking down those financials to show the contribution of acquired hospitals versus affiliations. So that's 1. Number 2 is statement of operations for Yale New Haven Health Systems and any affiliated hospitals through March 2023, so 6 months. Number 3 is the final.
Sorry, can you just pause there? And,
Yes.
So it's a statement of operations, not for the system generally, but for just the acquired hospital.
I'm sorry. What's wrong with that? It's actually for the Yale New Haven Health Systems and the hospitals that are affiliates. Bridgeport.
It's the consolidated
System.
Yes.
but broken
okay.
out by
Yes.
delivery.
Yes.
And I'll issue a written order tomorrow too. That contains all of these, and if there's additional clarification that's needed, you can always respond to that. We can address it at that point.
Moving on to number 3, final fiscal year 2022 audited financial statements for all 3 Prospect CT hospitals and non-hospital entities that have an audited financial statement. Number 4 is the service utilization data for both Lawrence and Memorial and Bridgeport Hospital, separating out Milford campus. The utilization data should include inpatient, outpatient, and affiliated service lines. So inpatient separated for DRGs, outpatient by CPT codes, and the time periods for each hospital should include pre-acquisition services, 1 year post-acquisition or post-implementation of the 4-phase integration plan, if that took longer than say 1 year, at the acquired hospitals, and then 3 years post-acquisition for Bridgeport Hospital, separating out Milford campus again, and 5 years post-acquisition for Lawrence Memorial.
So I'm going to be clear again, this is Chris O'Connor. We do not have pre-acquisition data.
Sure.
So we can only give you a baseline of, let's say, the first quarter post-acquisition, and then we can do the 3 and 5 year look.
Sure, whatever you have available. I know we were discussing sort of what is available and is not.
Okay.
So.
The other thing is that we had agreed to do an example hospital, and the example hospital was Milford. So I assume that's still fine.
So after further discussion about the types of hospitals that are being acquired and kind of the other discussions later on after we had asked that question. We think that Lawrence Memorial almost sort of represents what Waterbury might look like as an individual, and then Bridgeport Hospital, having taken in Milford as a campus, will somewhat resemble the potential relationship between Manchester Memorial Hospital and Rockville General Hospital. So that's why we're asking for both, just to get the examples.
Yeah, I'd caution on trying to draw, any true comparison. They're very different communities, very different hospitals with very different services. So I think we can see what we can do, but
Sure.
I think, as I said earlier, when we were talking about this during the Q&A period, that Milford, with its just recency, provides us the best opportunity to give you the most detailed information.
Yeah.
So, but if we can do the same for Lawrence and Memorial, we will do that.
I appreciate that. And honestly, it's just to try and get the examples of the services. As you mentioned, we want to examine your track record. So
absolutely,
that's what we're trying to do here.
Yep.
And in the written link files that you're gonna provide, can you note, instead of pre-acquisition, since you don't have it, that it would be the baseline for the first quarter instead of pre-acquisition?
Number 5 would be metrics on Yale New Haven Hospital System recruitment advantages or successes. Part of this late file can be submitted as part of the previous late file, as we had discussed during the questions. Additional narratives regarding the placement of Yale School of Medicine faculty or NEMG clinicians, or specific recruitment successes such as the description of New London or telehealth advancements can also be part of this late file. Number 6 is quality of care measures for Lawrence Memorial and Bridgeport Hospital, providing baseline measures and then quality measured trends post-acquisition. Number 7 is narratives describing examples of achieved cost savings at acquired hospitals passing on to patients. And so I think we were discussing the 2 types of savings that were passed on and then trying to break that down and get a clearer picture. Number 8 is regarding the Manchester Memorial Hospital PET CT scanner. We would like for the applicants to provide information describing the current arrangement, the proposed services requiring the scanner under Yale New Haven Hospital, the health system, if the application approves, and then the equipment plan, if approved. So current arrangements, proposed services that will require it going forward, and then the equipment plan for that machine.
Can we also do a supplement so it's also included as part of the acquisition as well?
So CON acquisition.
So that
of
we
equipment
have
supplement.
that service noted that's already being provided.
I think we had discussed that, but we will do both.
As well. Number 9 is separating and resubmitting any combined tables that contain ECHN data into Manchester Memorial Hospital and Rockville General Hospital specific tables. We won't be listing the 3 example tables that Hearing Officer Chuka mentioned during that question, but please provide it for all and any combined ECHN tables that were previously submitted.
And again, yeah, sorry, we will look again, but we have confirmed that both for projections, our model did not break out. So for forward going projections, they were done based on ECH and Waterbury. There is no breakdown that we could provide. And I think that for the things that they had breakdowns, they did provide them in terms of like the geographic race, age, et cetera. And some of them they could not. So we will just confirm that we cannot provide that, but I think the answer is we can't.
Okay. Number 10 and 11 are actually both the last 2 issues that we had posted to the portal for the pre-hearing issues. So the first is regarding the RFP. It states information and documentation related to the request for proposal or RFP process preceding the proposed acquisition that may include, but is not limited to, asset purchase agreements, competing RFPs, and presentations on the topic of RFPs given to the Connecticut Office of the Attorney General. That's number 10. And number 11, again, taken from the issues, is applicants' filings with the Federal Trade Commission related to this application and any notices or documentation of approval from the FTC.
I think we can at least speak briefly to those two items, and maybe taking them in reverse order. You know, we had a suggestion on how to handle the FTC AG piece of things, and Bill, as a time, can provide a little bit more detail around that.
Sure, we met, as I think I said during the Q&A, we met with the Attorney General of the Federal Trade Commission in February of 2022. And we made a presentation, which included data that ultimately was included in the Hart-Scott filing, but based on what we heard you describe as the purpose for your review, we think providing that information, if we can do with that in executive session, might answer any questions you have about that. Again, it would have data about our market share, as well as other health systems in Connecticut, looking at the potential for transactions with the prospect hospitals.
And it would be the same presentation that was given to the FTC and the AG's office. So we would look to do that in executive session, because obviously this is not a confidential format.
So your preference would be to do that right now in executive session, or do you want to provide it
I think we would want
in a
to
written
come
form
back.
directly to us?
Not in a written.
I think we would recommend coming back because we don't have it ready today to share.
Okay.
But we could come back for an additional session that would be closed and provide it that way.
Okay. I think that'll work, and we
Okay.
can coordinate when that can be.
That's terrific. And I think they're gonna propose essentially that, you know, that same time, come in to, we cannot be present for their description of our RFP process, except at the high level of the process itself. So Michelle, do you want to add a little bit of detail around what you would propose as well?
I think what we can do is share, so you have some confidence that in the RFP process, in terms of the selection on the preservation of provider diversity and patient choice, and talk a little bit about, you know, the other proposals, to give you some assurances on that. And we would propose we do that as well in executive session, you know, sort of at the same, you know, same time, but different group each back to back, I think.
Okay, that'd be fine.
Okay.
And that concludes the list.
We want to confirm in that executive session, obviously, it would be confidential, not subject to FOIA. And there'd be no, you know, nothing in the record.
Right.
Or transcribed.
Well, it will be transcribed, but I'll say, executive session, confidential, et cetera. I think we're required to do that by the FOI.
We'll all look at that.
Okay.
That's why
I mean,
sure about
I'm not going to be posting it to, you know, portal or anything like that, but I think we are required to keep some record of it.
We can take that offline in terms of legal requirement.
Okay.
We had one follow-up clarification request on the quality metrics question. You said it basically from the, you know, starting period of university institution, and then showing trends. Was there a specific time period? You know, obviously for most part, it's less than 5 years, but are you looking for, you know, essentially like 5 years? If we had it, or whatever we have.
Exactly. Yeah, very similar to the fourth one on the utilization data. This would be 3 years post acquisition from Milford, and then 5 years, whatever trend data you might have for LNM.
Okay, thank you.
Thanks for that clarification.
And then we can honestly talk about timing. We would suggest 3 weeks if that is acceptable to you. Some of these data requests may be fairly long. And hopefully we can conduct the executive session piece in the interim and accomplish that as well.
That's fine with me. I was actually going to say 4 weeks, given your comments on how difficult it was probably going to be pulled together.
We will, if we need an extension, we can let you know, but we think we can accomplish it.
Just one thing I will note is Attorney Wong will probably not be present for attorney.
I appreciate that.
Mr. Wong will probably not be present for the executive session. So That someone else may be present is my point, a different analyst. Okay.
Do we have the memo on the consolidation? Was that? noticed?
Yes,
Yeah.
that was.
Yeah, that's not really, I guess that's a late
It's-
file, but it's more like legal in nature. I would think you can have until the same deadline, 3 weeks. If
Yeah.
that works.
Yeah.
So I'll write something about that in the order. It just won't be included as a late file per se. Have any additional questions? Concerns?
No,
Okay. And did either one of you want to make a closing remark?
I'll defer to Kim.
I would like to defer to my client, Mr. O'Connor.
Well, I'll be very brief. I just want to say thank you. Thank you for the diligence and the opportunity this afternoon, well, all day, I guess, to spend focusing on this very important transaction. As we've said all throughout, we believe that it's in the best interest of both of these communities to complete this acquisition. And we're especially sensitive, and I made sure in my comments to elaborate that you know, it's a very difficult time in healthcare, and that approaching this differently is going to be essential for our success in the long term. So thank you.
Thank you. And thank you to everyone still here. And thank you to the public as well. So that concludes today's hearing. As I mentioned, I'll be issuing an order tomorrow that includes everything that we just discussed. And thank you so much for your time and your efforts. And thank you.
Thank you.
Thank you.
Thank you.